And this is Dr. Dragan and myself. Today, we, along with our colleagues from Canterbury Hospital and East Kent Trust, other sites as well, it's a privilege to bring you in. And today, the most important thing is we are going to welcome you. And the theme this year is Regional Anesthesia for Equity, Access and Relief for Pain, especially around enhanced perioperative care and beyond. So a few things. Most important thing, we would like you to have fun while you are learning. This is very important. And we would like to extend our sincere thanks to all our supporters, our sponsors. Please do go and visit their stands as well when we are having a break. These are our lovely faculties giving the lectures in the morning, and I'm sure more people will be joining in because we are expecting some more people. And if you scan the QR code, you will get access to the app by the ESRA. There are a lot of recorded lectures, videos in there as well, and you can get access to other recorded webinars from all over the world as well. So please do visit. There is a lot of information, very helpful information that you can access from there. Yeah? You all had a way to go? Yeah? Or okay, is it a little bit small? Okay. What we can do is just visit the ESRA World Regional Anesthesia Web Day page. There are, it is free access for all. There are quite a lot of YouTube videos as well you can access for free. Yeah, I can send as an email to all delegates after this one as well. So these are our lovely faculties who are going to be there. We have got chronic pain consultants, a regional anesthesia specialist, A&E, and ICU people as well, because we are trying to spread the word of regional anesthesia beyond the operating theater. And housekeeping rules, fire alarm, we are not supposed to have any fire alarm today, so if you hear anything just behind you, that is the door. The hands-on workshop is one level down in the afternoon. Again, same format, fire exit there, and the assembly point is just underneath that light thing there, okay? Toilets, female toilet is at next level down, male toilet is here. And the coffee, lunch, as you can see, coffee and lunch up to the lunch, we are here. After lunch, the tea, coffee will be downstairs in during the hands-on scanning session. Now, our models today are our colleagues from the hospital. So please, if you take any pictures, ultrasound pictures or whatever, please get their permission. Please make sure you are not taking any of the person's photo in there, and please do not put anything on the social media without
No, the thank you. There are a lot of people that I have to thank in this organization. It's Nuala, of course, as the chair of the activity. It's Sebastian Bloch, the person who will take over after me in September as president of ESRA. It's the trainees, it's the office team, it's the sister societies, the endorsing societies. The new thing is that we have the support, the strong support by World Health Organization with strong messages because they understood what we do, that we try to offer a universal health coverage. So many thanks to all of you, to every speaker, to the organizers there, to all the participants that have spent their Saturday morning to be with us, to be with you, and that are at the heart of this movement. Today, we are all together gathered worldwide, and let's make a promise that geography will not longer decide who suffers, that knowledge in regional anesthesia and perioperative care and pain management will travel faster than inequality, and that compassion will guide our science. Because the future we are building is simple, and it is just like that. Where care is possible, pain should not exist. Thank you very much from my heart. It's not the president, Eleni Moka, who says the thank you. It's your friend, your colleague, next to you every time, every moment, with the vision, if I may say, that we can make this activity even bigger next time. Thanks a lot from my heart, and good luck to your activity.
Thank you. Thank you, Eleni, for joining us. It's great honor and privilege that you were able to join us live. And now I will ask Professor Nuala Lucas to give us a few words regarding this as well.
Thanks, Asmaya. Hello, everyone. I can't see you all, but I'm pretty sure if I could see some familiar faces. I feel slightly embarrassed because I'm primarily an obstetric anaesthetist, though we are, I'd like to think, a big part of the regional family. But what can I say about regional anesthesia and World Day? Well, I think what I really like about it is that it reminds us that we're part of something much bigger. We work in a community
Thank you, Ritu, for the wonderful introduction. Good morning, all. Thank you, Atma, for giving me the chance to present today. Welcome for the World Day of Regional Anesthesia and Pain Medicine. Our motto today is to equity and equality in pain relief. So first session, we are starting with WHO ladder and beyond. In this topic, in this lecture, I would like to cover four stages. One is current WHO analgesia regime and what is missing in that, and what is beyond this WHO ladder, which we are following all around in our health sector, and what will be the future, how we can bring the equity into getting equal pain relief or better pain relief for all patients, irrespective of their general conditions or type of surgery or whatever it is. So bringing equity, how we can bring that, that is the aim. Current any sensory input needs a transducer, the mechanoreceptors or pain receptors, which will convert that pain stimuli into a electrical signal and go through the peripheral nerves, and it is transmitted to the dorsal root ganglion of the spinal level, where the modulation happens. Second order neurons reaches the brainstem, and from there third order neurons projects to the higher centers, and we perceive pain from that level onwards usually. So A alpha, beta, C fibers, which is peripheral nerves coming, and the local area non-steroidals works, spinal cord and brain area opioids and paracetamol works. Neuromodulation and local anesthesia effects are missing in this WHO ladder. If you look at the number needed to treat of oral analgesics, you can see that ketorolac is 1.8 and codeine 60 milligram is 16.7. So you need 16 patients to be treated to get one patient effective pain relief. What will be the number needed to treat with the regional anesthesia? If you do it correctly, it will work in all patients. Exceptions are there, channelopathy, where sodium channels are different, it might not work. Otherwise, do it, it will work. We do a lot of below knee amputations and above knee amputations, major lower limb amputations here. Be implemented to control the pain of the patient. Another thing is the patient's education is very much we do, which we miss in acute pain management as well, but we should be incorporating those into our acute pain management too. If you look at this, the chronic or persistent post-surgical pain developing, there are so many causes. The GA or spinal or opioid using the anesthetic, regional anesthesia during the anesthetic time will not produce much effect on development of CPSP. But if you look at the other factors, the inner circle there, the surgical and pain, what type of pain it is, and holistic approach is needed, and we have to put the patient in the center of the care. Then only we can address it properly. One size do not fit all, and protocols will be difficult to implement because the variations.
As always, that's added cost of dedicated room, dedicated staff, and dedicated equipment. Although it's very, very difficult to quantify economic benefit from block rooms, because first of all, it's highly contextual. It differs from one hospital to another, from one trust to another. And again, we as the clinician, we are not very good in creating business plans and selling them to the hospital management. But let's see, is there any time savings with block rooms? So this was the first meta-analysis examining literature about the parallel processing of patients having regional anesthesia, and included about 8,000 patients. So primary outcomes were like anesthesia control times, which is defined as the time between patient entry into theater to skin prep, and then from skin closure to patient exit the theater. And for every case, there was a reduction of 10 minutes. Again, the turnover time, which is is defined as the time from patient exit the theater till patient enter the theater, was reduced for 16 minutes per case. And impressively, the time spent in the recovery was reduced for 26 minutes per case. And overall, almost 2 cases on a list, 2 extra cases could be added on a list with the efficient block room, which is really impressive. There were some concerns because actually this parallel processing means interruption of continuity of care, because one team is performing a block and then the patient is transferred to another theater, to another team for intraoperative care. So there were some worries and concerns about the efficiency of the block and safety of the patients. So this is a big hospital, it's a Royal Brisbane Hospital, and they introduce so-called anesthesia teams comprising of block rooms and dedicated block teams as a quality improvement project. And then the primary outcome they were looking at was inadequate pain relief in a recovery room, which was defined as a numerical rating scale more than 5. So before the introduction of block room, they had like almost 44% of patients having regional anesthesia and then reporting inadequate pain relief. After introduction of block room, it was only 28% of patients. This is a good environment for high volume, busy lists. But at the same time, this so-called surgeon case profiling is extremely important. So that means that this list requires a specific surgeon. So surgeons who are predictable in their operating time with minimal variability. So we can plan and schedule a list. In many hospitals, they have a special computer-based simulation, which are based on previous data to tailor this list according to the surgeon. Again, resource constraints. You can have a perfect block room, but if you have a small, inefficient recovery room, very soon it becomes overwhelmed and blocked with all these patients coming from the block room, and it becomes a bottleneck. Again, low complexity procedures, they don't really benefit from the block rooms, because there will be some time savings. The list will not overrun, they will finish early, but then there is not enough time savings to add an extra cases on this low complexity procedure. Equally, a very long complex cases, they won't benefit. So there's no point of having too long cases and then using a block room. Again, keeping a permanent staff retention is extremely important. Again, it's evidence-based that permanent staff adheres to safety protocols better. Things like stop before block. And then at the same time, interestingly, if you have a permanent staff on the ward or in the block room, the incidence of hospital-acquired infection is much less than if you rely on agency staff. So basically, the block room is improved clinical outcomes, very efficient blocks with low complication rate and increased patient satisfaction. Thank you.
Thank you, Dr. Nenatic, for a very comprehensive view on block rooms. And I'm sure a lot of the trainees that are present today will be very grateful for you bringing them into it and appreciating them. We're going to move on to the next lecture, and this is with
years ago, that we need to think beyond that operating theater and the recovery, how we can bring the analogies here to the wider aspects. So now officially ESTRA has agreed, they have taken over this idea, and we have formed a new committee for purpose, which I will be talking about. And we are trying to bring or bridge the gap between acute pain, chronic pain, cancer pain, transitional pain, pediatric pain, obstetric pain, elderly pain, all pain together under one umbrella, and that should be purpose, perioperative pain optimization service. That is the missing puzzle that I'm going to talk about. So why we need it, how, why we should think outside the box, the future, especially changing the pain management paradigm. Two previous colleagues gave very wonderful lectures how we can bridge the gap together, and the concept purpose, which is going to be under ESTRA banner. And some final take-home messages. So we all know that chronic persistent post-surgical pain or persistent post-surgical pain is a big issue. okay? And this is the incidence. Certain surgeries give you more incidence, for example, breast surgery, hernia repair, knee surgery, and amputation. Amputation, 80% incidence of persistent post-surgical pain. And Dr. Param was showing you how the lifestyle factors play an important role in development of persistent post-surgical pain, more than what we do as an anesthesia, but what we do as an analgesia option makes a big difference. And the surgeons, their technique makes a difference as well. But out of all this, it is the patient and the patient factors which makes a big difference. This is a rather very complicated slide here, just to tell you how complex it is. So it is not just bringing the patient, do a surgery, give some paracetamol, non-steroidal anti-inflammatories and opioid. They are happy in the recovery, goodbye. We have to go beyond that, okay? So this is an article that is published, how the lifestyle factors in chronic pain management itself plays a role in reducing the burden and making the outcome better for you. So in future, any changing in the paradigm should include the perioperative optimization, especially the preoperative optimization, and that should include the patient lifestyle factors. Anesthetic factors, of course, regional anesthesia needs to be part of our paradigm, and we need to educate our colleagues, surgical colleagues as well. Why lifestyle factors are going to be becoming very important? By 2040, it is predicted these are the 4 major diseases, which is diabetes, anxiety, depression, and chronic pain are going to consume majority of the healthcare spend. So we need to treat them now rather than complaining we don't have enough resources. So the lifestyle diseases, male, female, which I will be giving a lecture afterwards, why it is different in male and female, and also preventive aspect as well. Some of them are preventable or curable, most of these lifestyle factors. So principles of multimodal perioperative management, how it should look like. It should start with the assessment. Whether you are a surgeon, whether you are an anesthetist, during the preoperative period itself, we should start seeing, this is where the pre-op assessment clinics are important as well. We can influence the patient outcome. Optimize them. So POPs teams are there, but they are predominantly optimizing the medical aspect alone, not the pain. This is where, as anesthetist, we can play an important role joining the POPs team. When they are optimizing the medical aspect, we can optimize their pain management prior to the surgery, especially neuropathic component of the pain, because that is one big predictor for persistent post-surgical pain afterwards. Prehabilitation, rather than focusing on the rehabilitation, you need to focus on the prehabilitation, because the muscle function is very important, especially for joint surgery. So if you don't do that, there is no meaning in just replacing a joint. So the purpose is the concept of the changing the paradigm, okay? Why it is important? Because we need to modify the anesthetic factors preoperatively, avoid or reduce opioid as much as we can perioperatively, because opioid use is again another predictor. Regional anesthesia should become the major part of our analgesia and anesthesia. This will help to reduce the burden of chronic management perioperatively, and identify these risk factors preoperatively so that we can optimize them as well. So myself and 2-3 other colleagues, we wrote a editorial last year or a couple of years ago, why we should start naming the regional anesthesia and pain medicine as enhanced regional anesthesia and pain medicine. Because we say enhanced recovery. And if you look at the enhanced recovery pathway, analgesia option is like a tiny little option in the middle somewhere. People are not even giving enough focus. This is where, as anesthetists, we need to come in and raise our voice and raise our concern. We need to shift the focus to the pain aspect, because that is the main reason most of the time why patients are coming to the hospital or having the surgery. So we need to do that as well. So how can we influence the patient journey? Anesthetic factors, I told you, surgical factors. Have a discussion with your surgeon, optimize their surgical technique as much as, but the most important, we need to shift our focus to the lifestyle factors too. So, as I told you, ESTRA very kindly decided to form a group, and I'm chairing the group, and we have got physicians and clinicians from all over the world part of the group as well. So we want to bring the expertise from every component of pain, pre, intra, post, chronic pain, acute pain, cancer pain, pediatric pain, obstetric pain, all pain that you divide, we want to bring them together, and we want to guide the teams and also physicians how we can bridge the gap together. There are a lot of challenges, as we can see as well. So you see, one is resource. All over the world, everybody is not fortunate to have multidisciplinary teams. So you need to adapt these techniques according to the resources available for you, the clinicians available for you, the skill mix that we have as well. But one thing is important. If we educate ourselves about the lifestyle, wherever you are, you can influence the patient's pathway by changing their lifestyle factors. And learn transitional pain blocks. We have a live demo of transitional pain and the concept of transitional pain later at the end of the morning session. So you learn from acute pain world and chronic pain world, it doesn't matter. It is a block which can be used vice versa. Okay, so this is something that will. And also pharmacology, beyond the WHO ladder, we need to think about what else can we add to the paradigm to make it better for the patients. Standardization, we all agree, yes, we need to have a framework, but at the same time, it needs to also include the sex and gender differences, the population, the genetic differences, and also the resource differences as well. So we need to consider that as well. So as a group, the purpose is a perioperative pain optimization. I would encourage you to please check it out at the ESHRA website, and we are just starting. It's a big starting point for us as well. Please join us, contribute. And the future plans are, as I explained to you, we want to develop guidelines and also research around various gaps that we are seeing in our clinical practice. So be one of us, join us, and it will be a great help for everybody, for us as physicians, as well as for the patients. So as a take-home message, I will say persistent post-surgical pain is a significant problem that needs urgent attention and can be predicted and prevented up to an extent. Think beyond just a WHO ladder based on the pharmacology and also just the needle tip. I did a block and that's it, end of the story. Okay. Purpose is the perioperative pain optimization. We need to join our hands with the POPs team, which are the medical optimization team, and make it as a component of the patient journey. Patient factors, probably the lifestyle factors, are the most influential and important factor, which is modifiable. So we need to get educated as physicians how we can assess these patients. Simple things like stopping smoking, losing weight, because 1 kilo of weight of the patient on the knee is 4 kilo of stress when they walk. So even losing 5 kg of their weight makes a big difference in the outcome later. If they have got neuropathic pain pre-existing, they are on high opioids, reduce it, give a block, genicular block, which you are doing after the surgery, prior to the surgery, enhance their prehabilitation. This is very lot of things that we can do. And thank you very much for listening. And with that, we welcome you to our RE UK meeting in May as well. Please come and join us. Thank you. Thank you for your time.
Yeah, thank you, Atmaja, for a very thought-provoking talk. Yeah, we're going to move on to the question and answer session, so I'd like to invite all three speakers to come forward. Anybody in the audience got a question for any of them? Go ahead, sir.
Good morning, all. Thank you so much. Very, very interesting. I totally enjoyed it. About the pain, the first lecture, I'm a bit surprised that in anesthetic and in medicine, we don't talk about some of the medication that are traditionally tabooed, and they have a bit of bad omen, like THC or other neuromodulators, and we don't talk about them, which there is lots of good indication that they are going to be useful. That's one thing. About the pain room, it's a very good thing, but in a smaller hospital, it's difficult. Why we cannot use anesthetic room? And I have a bit of debate about the training because it's going to be a bit higher blocks for more experienced people, and the junior doctors are going to completely miss it. And in the last lecture, NMDA antagonist for the chronic pain is an important thing that I think it was missing. So.
Thank you very much for very few interesting questions. So he can start answering those questions, and then regarding the block room. Yeah, so there are various medications, of course, that we can use. Yeah, so can you just repeat that first question?
Neuromodulation.
Yeah, there is a neuromodulation lecture coming as well, but of course there are various pharmacological agents that you can use. So the neuromodulation itself, yeah, the neuromodulation is not just the electricity. So we always say there are physical methods of neuromodulation, which includes even limb elevation, massage, yeah, heat application, psychological, stress management, that is all neuromodulation, yeah? That is non-invasive neuromodulation. Then any medication that you use is a pharmacological neuromodulation. They work through various pathways of the conduction, nerve conduction. So any neuropathic medication, including the local anesthetic, which is one of the best ones for a regional anesthesia, you can be used. And of course, the newer technologies of electrical neuromodulation, which can be external or internal. So there are various methods that we can incorporate into the neuromodulatory world. Yes, that was a very good question.
We use regularly neuromodulation, electrical one, and also pharmacological one in vascular pain, ischemic pain in the wards. Our incidence of phantom limb pain is decreased drastically.
So we use percutaneous temporary neuromodulation using the conventional needles that we use for our block. You can connect to our nerve stimulator and change the parameters slightly, and you can stimulate, just like you are doing a pulse radio frequency neuromodulation. So you don't need very expensive equipments to offer neuromodulatory techniques in our day-to-day clinical practice. And I will definitely, if you are interested, we can give you the parameters and things like that and teach you as well. So just before performing the block, we neuromodulate, then block the patient. And last ESRA meeting, we put a poster comparing the efficacy of low volume, that is 4 ml of local anesthetic and neuromodulation for a reverse shoulder surgery, comparing with the conventional 20 ml interscreen block. And no surprises, neuromodulation with the 4 ml had better analgesia and reduced opioid usage. So definitely there are techniques that you can add to the thing as well. Yeah? Very simple technique. You don't need all these expensive. That is what I was talking about, the transitional pain concept. We need to bridge the gap between the two. Yeah, I will ask about...
Thank you for the question. So it doesn't work for the small hospitals, but for example, we have this elective orthopedic center. So with the high volume of blocks, the most cases we've done, it was 7 joints. So normally we do 4, only because of this so-called staggered approach. So that's this parallel processing. So I was sending for the patient while the prior patient was still in theater. Because normally for this, for example, for knee, we do spinal plus adductor canal or femoral triangle block plus IPEC plus genicular blocks. It takes time. So that's why you need a block room. So I said small centers, they won't benefit. But definitely something like elective orthopedic center will definitely benefit. Because we have many delays, checking sets, sending for the patients, lack of nursing staff, it's all adding. So I think just checking the sets probably adds about 2 or 3 hours on a daily basis for delays. Training, when I trained in Northern Ireland, I was in Musgrave Hospital, and that for the first time I experienced a block room. It's brilliant stuff. So as a trainee, I would be allocated there with a consultant, and on a day I would do sometimes 20 blocks. And I probably developed my interest in regional anesthesia doing all these blocks. So this definitely trainees adore. There's nothing wrong in block rooms and education, on contrary. Because you're allocated, so today it's me, tomorrow is someone else. They're planning to make it like a plan, like a part of curriculum, like part of the Royal College of Anesthesiology training. So it's brilliant stuff. it's really good fun for training. Yeah.
Yeah, absolutely. I mean, I visited Dr. Admir, Professor Admir Hasik Center in Belgium, you know, the Nysora man, yeah? So when we visited Admir, this is like a standard. And what most impressive thing about the visit there was how smooth it was. Everybody knew what is happening. So there was no question like, oh, what should I do, what should I do, what should I do? It was like such a well-oiled machinery. And they do like, 14 to 16 joints a day, like a knee or hip, whatever. So it is a smooth process. We here at Canterbury, we had a hand list, just like that, high output list, okay? So we did probably 16, 17 cases in a list like that. So how we did was, again, kind of parallel working rather than a continuous process, serial working. So we kept blocking the patients and surgeon kept operating the patients. And simple things like having all right-hand surgery in the morning or left-hand surgery in the morning makes a difference, so that you don't need to turn the table around, you don't need to change the hand table, a lot of things. And because they are having just a block alone, people will walk in, walk out. I did not even have a block room here at that point. So we blocked in the anesthetic room, but we managed to convince the recovery room people to look after the patient, monitor the patient with the big brachial plexus block. And in return, we promised them we will not take them back to the recovery. They will go back to the ward and they will go home straight away. They loved it because patients are comfortable, there is no nausea, vomiting, no pain issues, they walk in, walk out. Patients loved it as well. So we did have outcome measures and also patient feedback survey, and they all said, almost 99% of the patients said, I will have it again and I will recommend it to my colleagues and my family. One patient, this is again learning process for all of us. One patient said, I will not have it again. And we did ask, in the feedback form, if you have any concerns, please let us know. The patient said, I did not like the Harry Potter hand because they did not like the weakness or the numbness and lack of control. And she said, I would rather have pain over not having any control over my hand. So the patient perspective is very important in whatever we are doing. It is not about, oh, I did a fantastic block, it was 100% pain relief. What the patient wants. And it was a big learning point for me as well. Then I changed my technique. So nowadays, I do lignocaine block for the brachial plexus if it is something like a small surgery in the hand, fasciectomy or something like that, and do a distal block with the longer acting local anesthetic, so that in 3-4 hours they will have the hand function back but still have a painless surgical field. So you adapt your technique accordingly as well. So block room is a very...
back to the story of planning.
Correct.
So permanent staff, people who know what they're doing, people who perform together for a long time, selected surgeon, just based on previous data. So it's all about planning.
Yeah, and also if anyone is enthusiastic about starting that kind of thing, I would always recommend start small. Get your buddies, your surgeon, your team around you, because that is most important part of bringing any change to the clinical practice. But if you convince them, and also you have to become very good at your blocks as well, that is why we all are here, to learn from each other. So it is multiple factors rather than just thinking, oh, I can start a block room tomorrow and everything will be all good. Yeah.
I do a hand list every week, and I adopted mainly what you're saying, but instead of blocking the whole axillary block, I just do the musculocutaneous so they can tolerate the tourniquet and block the peripheral nerve with a long acting from the beginning. And the patients, I can move. Yeah, you can move because I didn't block your motor. So this saves on the slings, and patients are happy, and I just make them sure you're not feeling your fingertips. Be careful of the radiators, please.
Yeah.
That's it, yeah.
Yeah, that is again. And also one thing I wanted to erase from everybody's brain as an anesthetist is we do not need high concentration local anesthetic for your block. Concept of sensory block versus motor block, okay? I have one of my surgical colleagues here, he knows as well. We do elbow surgeries, and he is very particular about testing all the nerves afterwards. So we do pure sensory block, that is, using 0.125% levobupivacaine instead of 0.5. The 0.5 give you muscle paralysis as well. I use it for the shoulder, I use it for the knees, to be paralyzed for the surgeon to put things back. But for an elbow, because he is working very close to the nerves, he wants to test the muscle function immediately after the surgery. So just to make you all realize, sometimes we go in a kind of a tunneled view. We said, okay, 0.5 for all the regional anesthesia. So we follow that. I always say this. In chronic pain, we have a concept of pain ladder, McGill's pain ladder. Okay, so 0 being no pain, 50 being the highest pain, according to what the patient condition is, fracture, CRPS, trigeminal neuralgia, labor pain, things like that, yeah? So in that ladder, CRPS is above 40. So 50 being the highest, above 40 is CRPS. Labor pain is around 40. Okay, a fracture or a injury is between, like a surgical injury is between 10 to 20. If a woman can labor through without any pain using 0.125, I'm sure a man can have a surgery using 0.125 as well. Yeah? So this is something that we need to erase as physicians from our mind. I have to use higher concentration for the same block you can do, use 0.125%, that will give sensory block. Yeah? Any other questions? Yeah, there is one more question at the back. Probably after this, we will move on to the next session. Yeah.
Thank you for the wonderful lectures. The block room is a fascinating concept for me. But I have a question. Most of our patients, they are afraid to get an awake block. They request for a sleep block. So how do you deal with such challenges in a block room?
No, they don't fit. We got a
I sell the story. So I can't remember the last time I've done a hand list with sedation. So I try establishing a report, and then that's added benefit of block room. There is time.
Yeah.
So you have time to establish a report. I normally ask them to touch their nose. I use high concentration. I'm not brave enough. And the moment they realize that can't touch the nose, it's reassuring for them. It's reassuring for me. It's like a psychological game. But I said, probably over the last 3 years, I haven't done a single list with sedation at all. So initially, they're all very, very anxious. But I said, once they realize it's working, and we just simple chat, but you need time for that. You know, if you say, oh, you won't feel anything going in the theater, they're going to panic. Guarantee. So that's the additional benefit of a block room. So you have time to establish a rapport with your patient. So you just talk, chat. That's what I do, just establishing a rapport.
It is again, you know, like four important people need to be confident if you want to have a awake surgery. Most important person is you who is doing the block. Okay, you should be good, and also you should be confident in your own blocks, understanding limitations as well. There is always a chance of failure. So plan B, C, D, Z ready for you. Then your surgeon. Because surgeon has got a big role here, because they can prepare the patient. Like the hand surgeon with whom I work, he does not even tell the patients, like you can have a GA for everything. They say, we offer this one. And they will put the word into their kind of, you know, conversation and say that that person is very good, you can be awake, you can recover faster, whatever. Yeah, so that is there. Your team around you, your nursing team, your recovery team, they need to be confident as well. When you all are confident, the patient will also have confidence, and they need a lot of reassurance. So the next topic is going to tell you how you communicate with the patient, how you put the idea forward matters, and it can have a huge impact. Again, be ready. Anything can happen. In medicine, never is never. Yeah? Even if you have done thousands of blocks successfully, there is always a possibility somebody might fail. And also, this is about a patient experience. If the patient is saying, I can feel it, it is uncomfortable, believe it. Okay? And also with experience, you kind of sense this patient, whatever you do, is not going to be comfortable. Yeah? So don't say that, rub your ego and say, oh, I'm very good at block, I will give you only block. No. Offer them sedation or GA. So the selection of patients is very important. For that, you need the entire team. Your best buddy is your surgeon. This is where working together as a team for longer makes a big difference. Yeah, permanent staff. They know, you know. So I always say, a small information, this is my husband, by the way. So I say my hand surgeon and my shoulders are like a work husband. So we don't talk to each other much. Yeah? But the other person knows what the surgeon can do or myself as an anesthetist can do. So your work buddies are very, very important for successful block and block service. Yeah. Yeah, one more question. Okay, so next is you.
Hi, thank you. This has been amazing so far. Forgive me, but being part of a nursing team and also a sufferer of back pain, I'm just wondering, when we talk about moving beyond the operating theatre, what are your views on staff with back pain, acute back pain? I don't feel we can be ignored because we are part of the workforce, and part of the workforce means that if you have back pain, then you're not necessarily going to be at work a lot of the time because of this issue. And just thinking forward, any thoughts, any one of you, on helping the workforce, nursing staff with pain and, you know, enhancing their performance because the lack of, you know, health regarding pain? Thank you.
It's a very good question. This is again, you know, we need to think about the people around us. Okay, if you have a general anesthesia patient, we need people to shift the patient and everything. These kind of manual handling aspect is prevented a lot if the patient is just having certain blocks for certain parts of the body. Not everybody. With the spinal patient can't move, but still, it is not like a GA patient. And just to specifically answer your question, here, a couple of years ago, we did suggest something to our trust, okay? Even though it didn't materialize, I still feel passionate about it. It is about having a separate pathway or like, you know, most of the companies have their own employee scheme. Like that, NHS or any healthcare sector can adopt that as well. Have a separate scheme with the physicians, with the supporting staff around who are available to support our staff. Like, for example, if 3 nursing staff are off sick because of back pain or whatever it is, yeah, you are struggling to provide the service. So making them better, quicker will benefit the service as well as the patient. But if you wait for 52 weeks in the NHS to see a pain specialist, that's hard work. So this is where you need to think not only the service alone, service provision alone, the patient, ourselves. This is what is one thing. As caregivers, we give least care to ourselves and our own colleagues. So this is something that we need to consider as a part of the human factors, which is another lecture coming in as well. So thank you all for joining, contributing, asking questions. And Ritu, just for your closure.
Yeah. Thank you, everybody, for the lectures, the 3 of you, and to everybody that's asked questions. I think that makes it a lot more interactive and ensures that everybody was actually awake through the lectures. I'm now going to hand over to the next session. And who's chairing? Who's chairing? Yeah, sure. So this is on perioperative pain management and personalized pain management even. Yeah. I'm going to hand over to Dr. Param, who's going to be chairing this session. Can I also just remind everybody, if you haven't registered, please make sure you have done the registration. Otherwise, we wouldn't know you've attended and you might not get your certificate.
Good morning. We are moving to the second session. It is innovation Innovation Club. We have got 3 lectures in this one. And first one is done by Dr. Vidhi Patle. She is going to discuss regarding the power of words in regional anesthesia and pain management. She is a consultant anesthetist and human factors course director at Darren and Gravesham NHS Trust. She is an anesthetist since 2000, and she has got MSc in critical care, fellowship in medical education, airway lead, and also anesthetic lead for learning difficulty patients. She has got special interest in difficult airway management and regional anesthesia. She is a rapid transformation therapist and clinical hypnotherapist. Don't fall asleep, okay? All, I will hand over to Vidhi. Vidhi.
Thank you. Good morning, all. Thank you, Atma, for inviting me here. Thank you, Param, for the introduction. So, my name is Vidhi, and I want you to just notice a couple of things, but we'll discuss that in a bit. I want you to think about why you think I put that cat bit there. Yeah? Just decide, just think what you think. And why did I put it in pink? And then we'll come back to it in a bit, yeah? So, yeah, go wild. Now, also the other thing I want you to maybe think about is, why do you think I would have become a therapist? You know, why from being a consultant anesthetist, doing anesthesia for more than half of my life, I realized actually, coming this morning, because I turned 49 2 days ago, and I've been doing anesthesia for more than 25 of it. So why would I, you know, after 45, why did I decide, after 43, why did I decide to become a therapist? So yeah, go wild with your guesses, and then we'll come back to it. So I'm going to give you 4 words to guess, yeah? Think of so they may or may not be related to the talk today, to the theme today, yeah, may or may not be related. And I've kept them easy, I've given hints as well. So just shout it out loud, yeah? Just say it. What is this word?
Ultrasound.
Ultrasound, yes, okay, correct. Majority said ultrasound, yeah, correct. Next word. Next word. Do not say the first thing that comes to your mind for some people in the, yeah? Think about what you're saying, think about the forum, and then answer. Pain, good, okay, very good. If you get any answer wrong, I will, what should I say, incorrect or losers? What should I shout? Whatever, okay. So next one now. Now, as we go ahead, I think, you know, I'll make it easier. So extra hints.
Okay.
Backache, yes, correct, very good. Now this is the last one. Losers. Noodle, that was noodle. I said at the start that it may or may not be related. So, why did the majority say that? Because that was like almost in unison, you said that. So 3 parts of our brain, yeah? Understand, simplified, 3 parts of our brain, okay? You know, the prefrontal cortex is what is allowing us to take all the executive decisions, right? Simplified, logical brain, okay? The other main part, what is more than 90%, is the emotional brain, right? That is the limbic system, the amygdala, we all know what that does, the pain, the fear, the anxiety, uncertainty, all that. And then there's a computer. Whatever goes by habit, repetition, becomes automatic. Like, you know, when you started driving, how you checked everything, tick, tick, tick. Now you just sit and you're talking on the phone, doing other things, yelling at children, throwing them in the back. And you can still do it right and safely. And if a child comes, you are able to still put a brake, and most of us drive safely because it's automatic. So computer is very powerful now. So 3 parts, right? One is the logical brain, the emotional brain, and the computer, right? Now, the logical brain, so the human brain as it is, has been for about 300,000 years, right? So it is that old. The life we live is very few generations. It's only like, you know, it's the kind of modern life we live is very new. So the logical brain has yet to catch up. It is not as evolved as our emotional brain. So, when you, did anybody, on the second slide, starting with P, did anybody think of any other word other than pain? Oh, good, okay, some did, yes, thank you, thank you. It would have been completely wasted otherwise. So, the emotional brain will, what it likes is, one is conditioning, experiences, part can be genetic, part can be cultural, but we jump to conclusions. The more evolved of us and the the self-aware of us, we like to think that we are non-judgmental, and we try to be, we do our best. But what happens when you saw that owned by cats, like, there must be some thought, what was I trying to do? Was I trying to be funny? Was I trying to, we all think, why does somebody do something? But we jump to a conclusion because the emotional brain does not like any gaps, no uncertainty. It will give you some answer to anything. So the first thing that you told, we're on ultrasound, the regional anesthesia, so everybody thought needle. And I'll come back to this a little more after the next slide as well. So now this, because I'm here talking to doctors, and we can be a skeptical bunch, we've been taught to be that we have to follow evidence-based. So, and also my title said there that I'm a clinical hypnotherapist, so otherwise you would think I'm talking woo-woo. So science, and specific science to anesthesia, right? Now, this study was in 140 women who were getting labor analgesia, right? Now, they said either placebo words or nocebo. So nocebo is the opposite. So there's no pharmacological effect, but still perception change will happen. So placebo phrase was, we are going to give you a local anesthetic that will numb the area and you will be comfortable during the procedure. The nocebo was, you are going to feel a big bee sting and this is the worst part of the procedure. Now raise your hands, how many of us use such a thing, worst part of the procedure? Sorry if you're attacking you for so many sides. We say so many things which we pick up as a culture. When I was in India, I trained in India for the first few years. When I was in India, I had different phrases which I picked up from my seniors. And why do we do that? Again, the emotional brain. We want to fit in, we want to be part of the crowd, we want to belong. And my language completely changed after coming here. Yeah? So then I picked up the sharp scratch, then I picked up because you fit in. And I have never said like, oh, I'm sorry, we're attacking, but everybody says that. And the patients seem to like when they say it. So you pick up, or you pick up by repetition because that's what you hear. So now, and then they did, after the local anesthetic gone straight away, they did the verbal analog scale. 3 versus 5 in placebo and nocebo group. That is hugely statistically significant difference, just by the word. This is how much, and how many things do we talk to them? We see them pre-op and while we're doing the procedure. And our words are going to stay with them. So this is just one study. This review article is a free article from Anesthesia from 2022. I would recommend, please go and read. This is relevant to all of us. And they've got in their references, they've got a whole bunch of other articles if you're interested. So you will get a lot out of this. Now, here, what I've highlighted in green, it says that what we say, hyperalgesia, because of nocebo words. Imagine next time, just try and be aware of how many nocebo words we use, or how many phrases we use. It causes rise in plasma cortisol, yeah? So we have functional evidence now. When we do functional MRIs, we can see parts of brain light up, literally, just in response to words and your expectations. So increased cortisol, and the phrases such as bee sting and sharp scratch. Now, anesthesia editorial, not just a therapist telling you to stop saying these, they have said these phrases should be thought of as clumsy verbal relics of the past. And whatever the context is, whether the context is research or clinical, the nocebo can no longer be ignored. So this is in our evidence. This is just anesthesia. In my therapy work, what I read, it is crazy amount of evidence is there. But I wanted to show you, because I'm talking to anesthetists, there's like massive amounts. We cannot ignore it. This is a really interesting one. In the same paper, they've mentioned this. So now this was a painful thermal stimulus given. Now this is what was going on in infusion, right? At the start, saline infusion, change over to remifentanil infusion without them knowing that this has changed. Now when they had the saline infusion going on, the pain score was 6.6, right? They were not told the Remi has started. So the pain score is still 5.5. Then they were told the remifentanil has started. So after that long, almost as same duration, because of the positive expectancy, the pain score went to 3.9, right? And then when they were told Remi is still on, they were told Remi has been stopped. So when the Remi was stopped, the pain score went back to when it was saline infusion, almost close to that. So that is how powerful this is and how powerful our words are when we talk to our patients. So this is linguistic priming. You know, you prime your TIVA line, you prime your needle. This is priming. What you have got has gone and sat in their heads. I had a colleague's birthday on Monday. She has got like really beautiful curly hair, like fabulous hair is the word I call it, right? On the WhatsApp message, I told her, you know, have a blessed life, have a healthy life, etc. And always have fabulous hair, I said, right? And then 3 messages below, there's a straight young man in my department. I don't think I've ever heard him say the word fabulous. But he said, oh yeah, have a fabulous birthday. And I have noticed this multiple times. Sometimes when somebody else has used a word, that word gets repeated. Because that is the word that comes to you. It was just given to you. Now we have, you know, the logical brain and the emotional brain. The logical brain, so the prefrontal cortex, you have short-term memory, right? You can only hold 4 to 7 bits of information in it at any time, right? 4 to 7. Now, if you have, so the halt mnemonic, if you're hungry, angry, late or tired, if that is taking all of your bandwidth, you have no bandwidth. Somebody comes and says the same thing to you today. You know why we've all experienced that we are different people on different days. We are different people in different situations. It is because of the linguistic priming. And because the emotional brain does not like uncertainty, it has to put in something. That is why we judge people. It is not because we are bad humans. It is because we are humans that will happen. But if we are aware, we can actually change how we behave. You may judge it initially, but then come back that, no, I'm judging my patient, I'm judging my colleague. Give an end point. When you're putting the local, you can say something like, yeah, this will just pass. It will pass in 10 seconds. It takes 15 seconds. Give them. And give them some sense of control. You can say things like, I will pause if you think it's too much. If they're very scared, you can say, I can pause if it is appropriate. So because some patients, we also know, they will say pause at every 2 seconds. So you can say, I will pause if it is possible for me at whatever step I am. So they have some sense of control. And it takes more energy to process the nod because, you know, just 4 to 7 things can be processed. So you should not say this will not hurt, it will not hurt too much. No, most people are very comfortable during this. That is how we must phrase it if you want to prime them. Now, these are some things in that same article that they tell us what you are saying now. This is the worst part, I'm sorry. Instead of that, you can say most people find this is easier than they think. So this is all in that article. And this is another one. You know, the one thing I'm going to say is here, one final check. If a patient is already coming scared that they're not going to wake up from the anesthesia, we know so many people do come, and then you're telling them, I'm doing one final check. So we have to think a little about that. Now so words is the smallest part actually of the whole thing. It is how you talk. So, when to build a rapport, if they are really agitated and talking fast, talking loud, you can start with the same. So what I've learned in my therapy is, nobody will open up to me because they all come to me with serious, big problems where they're vulnerable, right? They're opening up to me. So I have to build a rapport, otherwise they'll never share anything. So the thing is, you match your tone and pace with them, and then you slow it down. And then they slow it down, and they're breathing. And just 6 deep breaths, salivary cortisol, it's been proved that the cortisol levels actually drop. So we should do it. And when you tell them, so before I start my cannula, when before the IV line goes in and the monitoring is going on, I start talking and say, just nice deep breaths, not just pre-oxygenating from the start. And when they're doing the mindful breathing, they are not focusing on the 4 things that they were worried about, or the one thing that they were worried about, that I will not wake up, or whatever they were worried about. And then they are concentrating on the breathing, it becomes mindful, it brings down the cortisol, it'll make your life easier, it'll make their life easier. Now, this is the biggest part. This is literally, if you take one thing, this is what I want you to take from here. Body language is, when I say the jumping part, so, we've all had conversations where we've had an absolutely amazing conversation with somebody. Like, all the right words were exchanged. And when we separate, we're like, I should really feel great. I don't feel that good. Why is that? Because your logical brain is picking up only 5% or something of what is happening. Because, again, it can only take that much, right? But your emotional brain is doing everything. It is taking in everything constantly. Why do cats and dogs know that who to run to? They don't run to every person, right? I love cats, clearly. But if I'm in a crowd and there are 10 people, it is highly likely, 90% chance the cat is going to come to me. They just know how much I love them. How do they know? I haven't spoken any word. They don't understand my tone and pace. They probably do understand the tone and pace. But they do understand what I feel about them. So when you go in, and there's so many conditions where we say supratentorial or this patient's going to be difficult. If you're going with that mindset, your brain is only going to pick things that tell you that they're difficult, and they can read that. I will leave you with one interaction with one patient which is real. 22-year-old girl in A&E, I was told to come and do IV cannula for her. This is about 10 years ago, but I will never forget her face and the conversation. She was on like 12 medications for chronic pain. She was only 22. She was high BMI, difficult cannulation, and I was told she's difficult. She comes here for drugs repeatedly. That's why she comes to A&E. I was given that. I went and had a chat with her, did the cannula. I had a very non-judgmental chat. I reminded myself, she told me, you're the only person who's spoken to me like I'm a human being. So it's not the words. Nobody's gone and told her anything to her face, but it is your body language that they're picking up. So if one thing from the whole, it should be the body language. Yeah? Thank you.
Thanks, Vidhi. That was wonderful. It might help with convincing your patients to have the block when they are awake, yeah? Power of words. That is very informative and might be changing our outlook from today onwards. Next speaker we have got, here is Bruce Rung. He's going to speak about role of regional anesthesia in perioperative care, regional anesthesia beyond enhanced recovery system. So Bruce is our neighbor. He works in I will have the details there so that it will be correct, Bruce. Okay, so I will not be. So Bruce work in Maidstone and Tenbridge Wells Trust. So he's our neighbor. He's regional anesthesia lead and course director for regional anesthesia course and craft course for Plan A blocks. He is also involved with that very heavily as he is the organizer. Now I will hand over this to Bruce. so that he can continue with his presentation for you.
Thank you. Thank you very much for the introduction. Thank you very much for the invitation. And thank you very much for giving me the very small topic of regional anesthesia in perioperative care. Luckily, quite a few of the points have been covered, so that should make my life a little bit easier. So a few declarations. I am an avid regional anesthesia enthusiast, and I've mentioned some of my roles. Little bit of an advertisement for the upcoming course in May. If you want to hear more from Mathma and Professor Power, you can look that up on Book CPD later on. So, I'm just going to briefly touch on the role of regional anesthesia in enhanced recovery. I'm going to talk about two big theories, one of which is particularly more controversial. Go through some specific examples in perioperative care, and then just talk a bit about building a pathway around regional anesthesia and the benefits it can bring. So as Athma mentioned before, enhanced recovery after surgery, it's a big bundle, care bundle looking to shorten length of stay and reduce complications, improve patient outcomes. Anesthesia, in this overview, occupies that little square, and regional anesthesia a smaller component within that. It's mentioned in most guidelines, regional anesthesia, most of the ERAS guidelines. But if you look at the phrases or the language that's used, it's very non-specific. It reflects a variation in practice across the country and expertise and availability. But whenever possible, should be considered, should be preferred. And the reason being, although it makes sense, regional anesthesia, it's reducing your opioid requirements, which fits into the ERAS aims of improving functional recovery and avoiding side effects. It's quite a difficult thing to pick out as an evidence-based regional anesthesia within this entire bundles, because that's how bundles work. You look at them as a whole. So that's why I want to move on a little bit more to what else can regional anesthesia do? What else can it bring our patients beyond this just opioid requirement reduction and perhaps better functional recovery. So this is the first controversial one, is cancer. I'm just going to give a brief overview about why I'm going to talk about this and why it's become back around as a subject of interest in the last few years. But as you can see, the cancer statistics are very scary. Lots of people are going to get cancer every year in the UK. Lots of those are going to need surgery, and despite all the advances in treatment, whether surgical treatment or other medical therapies, a lot of patients are going to have recurrence. So any intervention that can potentially help with this is probably worth researching. And a lot of the enthusiasm for regional anesthesia and its impact potentially in cancer comes back from this study in 2006. So based on sort of preclinical data that showed in vitro studies that local anesthetics had an anti-tumor effect, there was a group that were looking at paravertebral blocks compared to general anesthesia alone in breast surgery. It was a retrospective study that showed quite a marked reduction in cancer recurrence rates, and this kicked off a huge bit of enthusiasm, quite rightly, amongst all anaesthetists, and especially regional anesthesia enthusiasts. But despite this sort of strong early signal from these studies, high-quality randomized control trials that were then followed failed to show the same benefit. So this was someone who's actually in that original group, Sessler, in a study that was published in The Lancet in 2019, showed there was no difference in local recurrence or metastatic rates when patients received a paravertebral block. And that's similar. Breast is probably the most highly studied, but it's similar results when you look at bladder cancer, colon cancer, lung cancer. There's a few studies that showed some positive benefits, but most of the high-quality randomized controlled trial evidence is negative. But the reason for sort of bringing it up is a paper that was published a few years ago by Badway et al., and they looked at peritumoral infiltration of dilute lidocaine pre-incision in breast cancer patients. And they have shown in their study a statistically significant improvement in disease-free survival and overall survival in these patients over a 5-year follow-up. Now, again, it might just be that this is kicking off another round of enthusiasm, and again, repeat studies may show that these effects are not reproducible. But the fact that there's potentially some form of evidence base there is something that's quite exciting, and obviously something that requires more research looking into. Talking about the role of lidocaine in cancer, we're awaiting the results of the Allegro trial, which was IV lidocaine in colon cancer patients, to see if there's any difference in local or metastatic recurrence in those patients as well. So chronic post-surgical pain, I mean, luckily this is being covered. I didn't want to get up here and talk about chronic pain. It's not my necessary area room with some of my other colleagues here. But what has been covered is that the risk, or what drives chronic post-surgical pain, is not simple. It's multifactorial. It's this biopsychosocial model. There's genetic components, there's social factors, demographics, all come into play. But we do know that uncontrolled acute post-operative pain is at least correlated to the development of chronic post-surgical pain. And I say correlated because the same factors, the same risk factors, the biopsychosocial model risk factors that patients may develop chronic pain probably also increase their likelihood of having uncontrolled acute post-operative pain. But it does seem a logical target, and anything we can do to improve patients' pain, reduce opioid requirements is going to be important. I think everyone's quite aware of the well-publicized, and both in the media, print media, and in the entertainment media when it comes to the impact of uncontrolled pain and opioid prescribing. So this is a slide to show that there's lots of steps amongst the pain pathways that regional anesthesia could have an impact on. There's strong sort of mechanistic logic for why regional anesthesia should help. But there's mixed results in the literature, and why is that? So it's really difficult to study chronic post-surgical pain for the same factors that we've just talked about. The incidence of chronic post-surgical pain is variable between different surgeries, and perhaps in certain surgeries, it's over-exaggerated, the incidence, which results in studies that then look into it being underpowered. There's many of the meta-analyses that have been done to try and sort of go past that problem. They also are limited by the papers that they actually are studying. So if there's no consistency amongst the randomized controlled trials in terms of what constitutes chronic post-surgical pain, about what scoring systems they use and what time frames they follow up, it's hard to bring those results together and provide a reliable result. There are some more recent higher quality meta-analyses that have been done, including this one that was published with the involvement of Alan McFarlane, which showed that there are certain surgeries in which regional anesthesia has a clear benefit in protecting against the development of chronic post-surgical pain, such as mastectomy patients and thoracotomy patients. But they failed to show benefit in certain surgeries like inguinal hernia repairs, for which rates remain high. So let's just move on to some specific examples in perioperative care. So fractured neck of femur. It's become quite standard now that patients with a fractured neck of femur are offered preoperative peripheral nerve blocks to help with their pain. And we look at the Cochrane systematic review that was updated in 2020. Their conclusions were that providing a peripheral nerve block in these patients caused a statistically significant and clinically significant reduction in the risk of delirium in these patients, as well as reducing chest infections and shortening time to first mobilization post-operatively. And with a Cochrane review concluding quite strongly that there is no need for further RCTs looking into the impact on peripheral nerve blocks and delirium. That sort of case is closed. The evidence threshold has now been reached. Critical limb ischemia. Critical limb ischemia is an extremely distressing pain and experience for patients. It's very difficult to treat. It requires polypharmacy. It can be refractory to oral treatment. These patients can have a miserable time where they're suffering. There's been an increase in the role of using continuous regional anesthesia by popliteal sciatic catheters in these patients. Previously shown in studies, but this was a very nice service evaluation done by Sharp et al. In Brighton, which showed that by introducing a continuous sciatic nerve catheter service, they saw significant improvement, not just in patient pain scores, but also in their sort of satisfaction, their mental well-being, their ability to function, to move around, engage with physiotherapy, and reduce their opioid requirements significantly. And what that does is it goes beyond just treating the patient's pain in this instance. It's creating an analgesic window which allows conservative management to take place. And beyond that, it might actually be impacting the disease process in these patients. You now have a chance where they can wait for longer before intervention, such as amputation or endovascular surgery, where they can have conservative management like the anticoagulants and physio, and it might alter their outcomes. And talking of altering outcomes and regional anesthesia, then we can also look at AV fistula formation. So we know that AV fistulas, they're going to be formed in patients who are multi-morbid. Commonly, the procedure might not be done under general anesthetic. It might be done under local anesthetic or brachial plexus block. And there was initial studies that showed that if you performed a brachial plexus block on these patients compared to local anesthetic, the vessel calibers were larger due to the sympathetic blockade, and the surgeons found that they were larger and there was better flow under ultrasound. So again, a team in Glasgow did an initial RCT looking at a 3-month follow-up for AV fistula patency, and they showed that by patients who had surgery under brachial plexus block had statistically significant better patency rates at 3 months. So this is regional anesthesia influencing long-term outcomes. And they repeated that study with another RCT looking at 1 year, and similar results were found. So again, this is long-term effects of regional anesthesia. So if we then talk more about the benefits that regional anesthesia can bring, not just in terms of to your individual patient, but to the population and service as a whole. This is a really lovely narrative review published in Anesthesia in 2021, which changed my thought process when it comes to regional anesthesia. We're looking at the patient population and healthcare and training as a whole, and the benefits that it can bring and what truly defines success within a pathway. So a lot of this has already been covered, but if you think of an awake upper limb service, if you design that entire service around regional anesthesia, it's not just a case of being safer for your high-risk patients, but you might be able to streamline your preoperative assessment, you can bypass recovery, you can shorten your length of stay, reduce your inpatient requirements, you can make environmental benefits, not just with fewer drugs, but fewer inpatient days spent in hospital. And there's huge benefits for the entire system and the population as a whole. But we must remember the patient. It's a balance. And as we've mentioned before, the technique of how you do it makes a difference. There's been some fantastic qualitative studies that look into patient experience, having surgery under block and having awake surgery in the operating room. And there's common findings, such as Athma mentioned, where patients don't like having a densely blocked arm post-operatively. They don't like the feeling when it wears off. They don't like rebound pain, obviously, if it develops. They don't like necessarily being in an alien environment without it being managed for them, being out of control. So unless we deal with those through education, through our technique of how we do the block, through our follow-up of those patients, then we can lead ourselves in a situation where you've done a successful block, but you failed the patient. And that's where I think regional anesthesia, where we need to move and where we need to shift. So sorry for being slightly too long on my talk. But in summary, I mean, regional anesthesia is not just an enhanced recovery tool. It's perioperative therapy for the patient. There are some long-term outcome effects, but it is challenging to research a lot of them. The system as a whole matters. The pathways unlock our full value of regional anesthesia. And we need to measure what matters to the patients. And the perfect block, as I said, isn't necessarily a success. So thank you very much.
Thank you, Bruce. That we will take questions after the session. Very interesting. Next topic is Dr. Atma. Men are from Mars, and you will hear. I'm not going to continue. I am not going to introduce her again and again. You know her, and for the people online may have joined later. She's a consultant colleague of Canterbury, and she's specialized in chronic pain and regional anesthesia. She's actively participating in the various projects by ESRA, and very eminent teacher. Actually, I learned a lot of blogs from her, and I know her for the last 30 years. She's good in teaching. So, Atma, it is yours.
Thank you. Thank you for your kind introduction, Parag. This is one of the very favorite topic, very close to my heart. I am representing more than 50% of the population in the world who are women. So I'm not standing here not only as a physician, but as a female, trying to convince, trying to spread the word, trying to educate, because I have to put up my hand and say, as a doctor, I was not educated in the medical system how to treat women differently and why it is important. So I'm going to talk about sex and gender differences in pain and pain management. As the saying says, men are from Mars, women are from Venus. That is so true. Okay. So I will cover the background, anatomical and physiological sex differences, which is relevant to pain today, and sex and gender differences, cultural bias in pain recognition and treatment, some specific pain conditions which are important for females, and also future, how we can apply inclusive, equitable strategies for the pain management. So background history, the modern medicine is built on institutionalized misogyny. When I was researching for this talk, I was furious, I was angry, I was in tears. The history failed the female population. Most of the physicians who developed most of the practical ways or the pathways for treatment, medical treatment, were men. They talked about men's syndrome, men's symptoms, treatment for men. The research is, and even now, we have that deeply ingrained structural bias within medical research, medical education, and even clinical practice that we follow today. Caucasian male of 70 kilo was the conventional medical model for most of the researchers, including drug dose finding studies. Even in rats, they were using male rats, not female rats. Females were considered as, how can I say, the data is all over the place, basically. Females face delayed diagnosis, underdiagnosis, unresearched, and also misinterpreted symptoms because we are not educated as physicians. And that clinical, cultural, structural bias and also abuse of the system in multi-level is still there as barriers. So women's health, even now, you look women's health, that is just bikini medicine. Reproductive or gynecology and obstetrics is women's health. Nothing beyond that is applied to women's health. We are whole human beings, and we constitute more than 50% of the population. So mind the gap in pain. That is why the International Study of Pain in 2024, the whole year was used as an educational year to improve the awareness. And we always say pediatrics, when we talk about pediatrics, we say children are not small adults. Women are not small men either. So don't try to put that research from the men into the women's world. And in chronic pain especially, a gendered epidemic is there. Women experience all autoimmune conditions almost 9 times more than men. I will tell you why it is. and also migraine and other conditions in females, that is more as well. What is the fundamental difference? The most important one is the biological difference, which is your estrogen and the testosterone. The other one is the hormonal differences affects everything, starting from the pain perception, conduction, perception in the brain, interpretation, and patient experience itself. So anatomical variation, one is muscle tissue plays an important role. The other one is the fat tissue because of the most of the fat distribution as well as the drug metabolism. And bone plays an important role because many of the pain conditions are musculoskeletal problems as well. And if you see the perception part, in men or the male model, the main important aspect is the microglia in the central nervous system, which transmits the pain into the brain. But in a female, this is more sort of a neuroimmunomodulation through the T cells, which starts in the periphery and then goes through the brain. As I already alluded to, all these anatomical and physiological differences matters for the drug metabolism as well as the physiological outcome and which drug works which part of the body as well. So we need to consider all these in our clinical practice. And the musculoskeletal system is another important aspect. Okay, if a patient is having a knee surgery, everybody gets the same physiotherapy, pre and post. Knee surgery, shoulder surgery, everything. One example is the Q angle in females, which is wider compared to the angle that is coming with the hip bone here. This affects why women get more osteoarthritis in the knee and highest incidence of persistent post-surgical pain and failure after knee surgery in women. We have got osteoporosis because of our genetic disposition and the pregnancies. And we start from a very low level with the calcium level in the bone. And this is one of the reasons why women get more osteoarthritis in multiple joints as well. And pelvic anatomy is different and the innervation is different as well. As wonderful creatures, women, we go through 5 P's in our womanhood. The first P is the puberty. Why puberty is important? This is the time the menarche starts. It is not only the puberty that happens in a male, then you have a diurnal variation of your hormones, but woman goes through cyclical changes of different hormonal orchestration. And it affects your pain experience and the drug metabolism as well. The second one is the pregnancy. And as soon as woman is pregnant, everybody's attention into the baby, not the woman. And most of the women get only paracetamol as an analgesic option, okay, because you can't have it. Perimenopause is another one. It is like nothing prepares a female for menopause and perimenopause. And medical professional research, if you look through, most of the research is around the pregnancy, that also pregnancy related, not the gynecological aspect, but perimenopause and menopause is very poorly researched area as well. Other pelvic pathologies like endometriosis and also hormonal changes like polycystic ovaries, this all affect the hormonal changes, affect the medicine effect in the body as well as the analgesia as well. The trust gap, this is very interesting because male physicians rate female patients' pain as less severe, okay, when they are assessing, and they think it is all in their head, yeah? It's all in your mind. And this unconscious bias leads to delayed diagnosis and treatment in women. And many pain is considered as normal. They say normal period pain, normal labor pain and peripartum pain, and normal menopausal changes that is expected. And the classical one is atypical chest pain. Even though women are 51% of the population, the research and also the description, Professor William Osler, he described the characteristic typical chest pain in man. And in his research, it is written, thesis, women come in with some symptoms which are not related to cardiac chest pain and they don't die. We do die. It is the #1 cause of death after menopause in women. And we consider any chest pain that is coming to the A&E because it is not a typical man's chest pain, that is not cardiac, and that is why women die. And all widespread pain syndromes that women experience because of the hormonal changes, it is all considered psychological and it is in their head. So the social, professional, and personal bias is there against women. the bias in pain assessment, the treatment from the professionals, and the societal cultures, because people are expecting women to get on with their life and take it as normal part of their womanhood. And the cultural difference is different worldwide. Certain part of the world, they wouldn't even recognize women or women's pain as a part of their day-to-day life or medical professional care. The sexual bias in medical research, I already explained to you. Did you know that women need 30 to 40% higher doses of opioids to have EQ analgesia? But normally, we prescribe less opioids for women thinking that they are small men. So they all get a little bit less than the man. And this is all started with that 70-kilo average male model, and it is still continuing, and we are still not getting enough research funding in females. So psychological difference is huge as well. Women produce almost less than 52% less serotonin than a man. And serotonin is one of the most important hormone for well-being and your happiness. So anxiety, depression, and emotional trauma and also stress is more prevalent in women because of the hormonal changes. And this changes with their monthly hormonal changes as well. That is why women in the first part of their cycle, with the estrogen part of the cycle, they are happy creatures. And when they go to the progesterone part of the cycle, especially perimenstrually, they become very moody. And that is because of the progesterone effect. And this is reflected even in the clinical practice. Imagine with a patient with the PMS syndrome coming for a pelvic procedure during their premenstrual period, and they will experience more pain. We do not consider that in our clinical practice. As I told you, the special consideration should be part of our policy making globally, because in many underdeveloped countries or low-resource countries, they may not even have health professionals or limited training experience in pain management, especially sex and gender-sensitive care, and national policies may not be even there. Limited opioid availability is another one. Many parts of the country, you know that some of them don't even have single anesthetist in their country, okay? And the multidisciplinary services that we form or we produce as a part of the policies from a Western world may not be applicable in those countries as well. So we need to encourage the world to form their own policies, but the underpinning principle should be the sex and gender differences when we make these policies. So the future, when we apply the inclusive, equitable strategies, which is important for pain and pain management, addressing the educational gap. We all, as physicians, we never had a training. Even pain training, if you are lucky in a 6 years training, you may have 8 to 9 hours of pain education, maximum, if you are lucky. And we treat pain day in, day out, yeah? Sex and gender-specific education, probably 0. So we need to change the curriculum. We need to understand there is a difference, and that has to be part of the policy developments. And future research should focus on male and female difference as well. As Bruce was telling, it is very difficult to form any kind of conclusion from the researchers and evidence because you are looking at the wrong outcome. So we need to make it very specific and then look at it. So all the research priorities in the future should be based on sex and gender differences. It is not only in anesthesia, but also in pain. And it should start on a clinical, practical basis. What you can do tomorrow, it should start with your assessment and be understanding. If you are assessing a female patient, they may experience pain differently. Pharmacological management, you have to adjust the dosage. Non-steroidal anti-inflammatories and opioids are differently metabolized in women, so you will have to adapt your technology. Even regional anesthesia is different metabolism. You need to consider that as well. And non-pharmacological strategies like a stress management, you need to understand women have less serotonin in their brain. It is not their problem. It is the way the physiology is. So regional anesthesia techniques, when we develop as a protocol, we need to consider that as well. We have literally no research done on how the local anesthetic or the block is different in a man and a woman. Patient factors, Param was already mentioning, as you can see here, the patient factors and the gender factors are more important along with the pain in prevention or the prediction. So focus on that, even though they say they are non-modifiable factors. Sex and gender is a non-modifiable factor. I would say the understanding of sex and gender specificity is important in our clinical practice. All the modifiable factors are equal for both man and a woman, but this is very specific for sex and gender. So people think, oh, what is lifestyle factors? It is all soft medicine. It's not like me doing a block or giving a medication. So this is a meta-analysis of the randomized control trials, 186 RCTs, with more than 15,000 patients' data. So this is the heat map. You look at this one, UC is the usual care, where you can see it is still in red, not the best outcome if you give the usual care. But if you add in all your exercise or even psychological input and their nutrition, which is all lifestyle factors, into the picture, the complication rate comes down, length of stay goes down, the quality of life improves, as well as the psychological and the physiological recovery is much better. As you can see, that goes into the green zone. And if you combine it all together, it gets even up to 97% outcome, better outcome. So sex and gender equality is not possible because man and a woman is not equal from an anatomical and physiological point of view. What we need is equity. For the equity, we need to have the social justice. Social justice will only come through education, policy development, and also understanding you as a man and a woman, understanding your own human physiology. So as take-home message, sex and gender differences has a huge impact on every aspect of human life and healthcare. Using WHO ladder for pain management is not adequate. We need a personalized, holistic pain management. And focus should shift from equality to equity. That is what is needed. Lifestyle factors are, again, very important modification factors for every aspect for a better outcome as well. And final tips from my side. Please do believe and validate patients' pain reports regardless of sex and gender. Don't say it is all in their head and they are all mad patients. Please don't. Avoid normalizing pain. Women feel pain which is genuine pain and it is not normal. Use a well-structured life course lens when you are assessing your patient. The puberty, the menstruation, the pregnancy, menopause, all part of this, and tailor it as a holistic, truly multimodal, culturally appropriate treatment available resources as well. So with that, I request you all to consider coming to the call of action. We commit as physicians that will follow evidence-based, equitable pain management strategies that recognizes and address sex and gender differences. And I would like to thank all these organizations who is joining hands with us today to take it as an important aspect, and this will be one of the important aspects of the POPO service that we are developing as well. Thank you very much for listening, and once again, come to our RAUK meeting.
I'm sorry, we are a little bit overrunning. I was scared to stop her. So. Could I call the three faculty members to come here, please? Any questions from the audience?
Hello, thank you very much, Atma, for your fantastic lecture. No question, but 3 things to add. This lecture must be a part of every anesthetic conference. Similar lecture is the need of the hour. The second thing is just to mention that if you see any research that is going on worldwide, pregnant females are excluded from every single research. You cannot get them included. And if you don't know this, you have to believe it, you research it, you find it out, and there is no justice for anyone. Just to add. Thank you so much. Thanks a lot.
Thank you, Sergey. That is very important. Actually, there is a longer version that Esra asked me to do with more references and more details. It is available free on the Esra website. Because we had to make it short, I had to shorten it way much shorter. But there is a lecture available. And also I have done a lecture specifically for obstetric population, which is available at the OAA website as well. So that is specifically for obstetric women. What are the options for pain management? Yes, as I told you, to start with, even considering man and woman is different is a starting point, and we need to get educated. Thank you.
Thank you for the lecture, it's very nice. But I'm afraid I have to disagree, because if I go and say I'm going to treat women and men differently, I'm going to get sued very, very quickly, and I don't dare to go to my wife and say, this problem that you have is hormonal.
You don't need to say this is all because of the hormone. It is just understanding. So you say, see, I have given a gram of paracetamol, I've given non-steroidal and 10 milligram of morphine to this woman. She is still in pain. Yeah? So just be, so this is something that as a part of my preoperative assessment, especially I'm doing a gynae procedure. Nowadays I don't do much. By the way, for my disclosure, I was an obstetrician before I became an anesthetist and pain specialist. And my interest was because of the pelvic pain, okay? So I saw the other side as well. That is why I'm saying we are not educated. Even as an obstetrician or a gynecologist, you are not trained to treat pain at all. It all falls onto us. And when I pre-assess the women, I do ask them, when was your last cycle? And by the way, if the woman is on OC pills, they experience more pain as well. Okay. So these are the little things that we should be aware of, rather than telling and beaten up by your wife. It is all in your head.
Thank you very much for the excellent lecture.
Yeah.
Yeah, thank you very much for the excellent lectures. I want to ask that, let's say if you are doing some orthoplasties, are you using some guidelines or policies treating different or prescribing different dose or to the females compared to the males?
Okay, so again, any policy development, anything, you know how difficult it is, okay? But as a clinician, you have the discretion, yeah? You adjust the dose according to the patient. When I ask you what is the dose of propofol, we are all taught what is needed to put that patient to sleep. Yeah? So analgesia, again, there is a guidance, but you understand it is not only the pharmacological one, regional anesthesia is a part of it as well. What can I do? Yeah, the words, power of words. And as Bruce was saying, we need to see beyond that era's restriction, how I can influence the patient journey, starting from the time I see in the preoperative period, throughout and beyond that recovery period as well, when they're going to the ward. So there is no policy. That is why I am raising my voice, representing, I'm standing here not, as I told you, I'm not standing here as a physician. I'm standing here as a woman. Yeah? We need to understand. We need to educate. We need to accept there is a difference.
So,
one more question.
One more question, last.
Yeah.
Hi, thank you. I wanted to ask this as a perspective from a medical student. So we're doing plenty of rotations in obs and gynae, general practice, so and so. So one of the things that I've been experiencing quite a lot and observing is women in premenopausal pain. There's a lot of pain that I've been hearing from women who are approaching their premenopausal stage. And it's quite difficult to approach those type of scenarios. How do you speak to them? How do you make them feel like you're not almost glancing over their issue? Like we as medical students, we really care a lot about learning and approaching these situations in the optimal best standard, but also sticking to guidelines. So we're still young, we still have a really long journey in our careers. So how can we implement changes now to approach these situations better?
This is a very good question. I will ask, all of you treat patients' pain. How many of you knew that frozen shoulder is a first sign of perimenopause in women. Can you see how sad it is? Not even a single hand is up to say, women, we are part of epidemiology. They say frozen shoulder is seen in women of XYZ age. But why? We never ask that question, why? And what can we do about it? At least now, the shoulder surgeons with whom I regularly work, because I have been telling these people, frozen shoulder is a sign of perimenopause in women because of the hormonal changes. And if you put scopes in and repeatedly scar the joint further, the pain is going to get worse. What they need is the hormonal treatment and optimization of their lifestyle factors as a part of the treatment paradigm, and they get better. Another one, recurrent UTI in perimenopausal women. Most of the hip fractures happen in women because of the recurrent UTI. They get UTI-related confusion, and they fall down and they break their hip. We fix the hip, but we never fix the recurrent UTI. And one of the most effective treatment for recurrent UTI in perimenopausal women is vaginal estrogen. Do you even consider as a part of your treatment plan? So this is where the education need to change, the curriculum need to change. And the most important factor for that is education, because education is power. At least these people sitting here, whoever is listening to me online through the YouTube as well as through the Zoom, it is a plea. Spread the word. You may be able to change the future. It was not easy for us. Yeah? As a woman who is going through the perimenopausal change, it is my own personal experience. Yeah? People don't listen to you. People don't understand. They say, have some physiotherapy. And what is important is it takes away that patient's independence and dignity. It may be very personal sometimes as well. And it affects them emotionally. That is one reason the perimenopausal women come to the GP repeatedly because of XY symptoms. It may be completely different. They have multiple joint problems, polymyalgia, widespread pain, and it will get a name, fibromyalgia. Yeah? So this is where the power of education is there. We can change. Even if you change 10 patients' life, that is huge. Yeah?
Thank you very much. Thank you, Vidhi. Thank you, Bruce. And thank you, Atma.
Thank you.
And now it is a coffee break. We are running...
No, 11:15. Be here. So coffee is just at the back. Move around. Men's toilets is on here. Women's toilet is downstairs.
Okay, women's toilet are downstairs.
So, yeah, no. and please be back by 15:15.
Thank you so much. I don't disagree.
request everybody to visit our sponsors' stands as well, please, while you are enjoying your tea and coffee. Thank you.
something to come, but nothing ever seems to make sense, so I'm done. I hope it's not too late for me. I aim to find a place to be the coolest person you have ever seen. Where are you? Please take me to the moon. Somewhere I won't be a tool. Yeah, let me fly with you. Don't you find it tempting to pack your stars and leave? No matter how crushing, pay that price to be free. I hope it's not too late for me. I tried to reach you. Where are you? Please take me to the moon. Somewhere I won't be a tool. Yeah, let me fly with you. Where are you? Please take me to the moon. Somewhere I won't be a tool. Let me fly with you. Where are you? Where are you? Where are Drawing lines on a window. Take my smile to your pocket. You got me, you and I'm losing to you, I'm a sinner. Time taking my mind. I'll never see you in the dark, 'cause you're shining bright. Why you leaving me now? I'll never see your soul inside, but I tried so hard. crashing my system. Give me some different places to hide. I've never wished you stay this night with me. I only knew I want you by my side. I'm searching for perfect shelter for you and me. Everybody think that I'm off still, but I want to feel. I'm taking my mind, I'll never see you in the dark 'cause you're shining bright.
Hello. Sorry to interrupt your coffee break. Can we all please come back to your seats? And during lunchtime, again, all our sponsors will be here. So visit them, because the last half an hour will be hands-on, the live demonstrations. So if we run out of time, that time will be squashed. So please do come back with your coffees, teas, biscuits, and join back. We will start the next session. So we are starting the third session now. It is such a joy, such a privilege, and such an honor to introduce our next speaker, Gina Susan Matthew. She's the consultant in anesthesia from Mid and South Essex University Hospital Group. She is also the lead for elderly trauma and regional anesthesia in the trust, and also the MSc lead for same-day day surgery anesthesia. She is also an ESRA instructor, course director for GOES. I really like that. Sorry I couldn't join you this time. This is, again, another course for Plan A blocks, which is normally run in January. And also, under her leadership, the trauma perioperative care for the hip fracture has won the National Hip Fracture Database KPI Improvement Award last year for improved performance across all 8 key performance indicators. So we will listen to her talk, how to prolong regional anesthesia blocks. And personally, I'm so pleased to welcome her here because we trained in the same medical school. And another small information, we were roommates. She was my junior, but we were roommates as well. And it is such a pleasure to see her again here. So over to you, Gina.
So thank you, Dr. Thotigal, for the very kind introduction. And again, sort of lovely memory seeing you again. So I'm going to talk a little bit about how to prolong regional anesthetic blocks. So the main topics that I'm going to cover are the rationale for extending the duration of blocks, rebound pain risk stratification, so we'll look a little bit into that, how we can optimize those risks, a little bit about prolonging the regional anesthesia, so different methodologies by which you can do that. So why regional anesthesia? So this review article by Turbit, Defining Success in Regional Anesthesia, looks at this measuring success in any healthcare system, and they define 4 foundational pillars based on which that success is measured. So we've already seen this slide before. So the main sort of 4 pillars are population, patient, resources within a healthcare system, and education and training. So they go on to say that regional anesthesia aligns itself very well in terms of enhancing all 4 of these pillars. So that good block that you do reduces perioperative opioid intake in the patient, therefore reduces that opioid dependence, and in that sense is good for that population health outcome as a whole. Again, that good block provides good patient experience, so a good sort of overall post-operative recovery, which in turn allows your patient to go home. So cost-effective for the NHS organization as well. So we know in the current NHS climate, there is a big drive for same-day discharge of surgical patients. And in this sort of meta-analysis by Zhang, they kind of look at, in addition to those sort of anesthetic and surgical factors, at the more sort of soft factors. So a lot of which we've already listened to today. And they identify those factors to have more of an impact in allowing your patient to go home the same day, rather than just the type of anesthetic or the type of surgery. So the main sort of factors they focus on is that sort of preoperative state of mind of the patient, the preoperative fear, anxiety, preoperative pain expectations, psychological factors, education level of the patient, so that lower education or level in patients give them a lesser understanding of pain and that sort of pain perception, all of which matter much more than your anesthetic or the surgery. But they do still say that regional anesthesia definitely provides better analgesia and in turn allows that patient to go home, with a little caveat that that should be accompanied by a good systemic perioperative analgesia. So we kind of know that, yes, your block is good, but it needs other things along with it as well. So this review, or this editorial by Eleni Morka, Transforming Perioperative Care, sort of emphasizes regional anesthesia as this transformative foundational pillar of modern anesthetic medicine. And the reason they stress for that is because it has the ability to provide individualized, tailored care to your patient and a very good overall positive experience for the patient. The one thing that they say might hinder that and provide a little bit of dissatisfaction is the presence of rebound pain. So rebound pain is a marked resurgence in that high intensity pain before resolution of your peripheral nerve block. And it is relevant to us as anesthetists or regionalists because about 40 to 50 patients receiving a peripheral nerve block have a chance of developing rebound pain, and it's higher in your ambulatory patients. And the importance of this is that it actually causes more dissatisfaction among your patients, reduces that sort of positive outcome from surgery, and even worse still, it might stop your patient from going home and in fact allow that patient who's sat at home to come back in because they're in so much pain. So cost implications for the healthcare organization as well. So suddenly that question arises, is it a good idea to do a block? So we are reassured in that by the editorial by Christopher Wu, who sort of reaffirms the fact that yes, regional anesthetic is good, because in those group of patients who developed rebound pain, about 96% of the patients said they would still have a block. So doing a block and providing regional anesthesia is a good thing. They also look at sort of several systematic reviews which sort of suggest that regional anesthesia might be associated with a decrease in postoperative chronic pain, even though in current literature there is no concrete evidence to suggest that it does, but there is a hint there that it does have an impact on chronic pain. And then all those other factors that we talked about in terms of the cost benefit and that overall positive patient experience. So we kind of understood that, yes, rebound pain has got a significant impact in that recovery of the patient. So what are those things? So it would be really useful to sort of identify those high-risk patients and bring about a change in their sort of perioperative experience of pain. So these are two sort of retrospective cohort analyses. The first one by Tim Jen in 2022 sort of looked at developing a risk prediction model for rebound pain incidence in patients undergoing foot and ankle surgery. Unfortunately, they were not able to they sort of looked at common things like, the age of the patient, the sex of the patient, type of surgery, type of anesthetic, but then they were not able to find an association between those risk factors and the incidence of rebound pain. 3 years later, Wang sort of looked at patients undergoing orthopedic trauma surgery, again with that same intention of identifying a high-risk group. And they were able to show that younger patients, patients who are female gender, patients who are diabetic, patients who have got preoperative pain, that psychological stress, anxiety related to that, a preoperative high neutrophil lymphocyte ratio, so that pro-inflammatory stage in the preoperative period, etc., were associated with a higher risk of developing rebound pain. So this in turn is sort of reinforced by the editorial by Hamilton, rebound pain, a distinct pain phenomenon or a non-entity. So rebound pain, like I said, is that sort of marked resurgence in high intensity pain before that block resolves. And they sort of reinstate, or they sort of confirmed the fact that, yes, the patients developing rebound pain are those same group that we identified again before. So the young women who's having bone surgery is that high-risk group. In addition to that, they sort of identified some modifiable factors as well. So the absence of intravenous dexamethasone, that sort of really high concentration, dense motor block, the long-acting local anesthetics, all of those, again, have a risk of developing rebound pain. So they talk about what are the things we can do to optimize that. And the focus is about patient education and managing pain expectations in the patient. And in addition to that, sort of modifying the regional technique that we use and making sure that all patients receive a multimodal analgesia. So in terms of prolonging that regional anesthetic, so non-interventional strategies, so things that we can do. And in the sort of systematic review by ADMASI, they sort of focus on education. So it's all about educating the patients, telling them about the existence of rebound pain, telling them how they can manage it, preparing them for that so they can manage it, empowering patients to utilize that bridging analgesia to actually take systemic analgesics when they're not in pain, which is so sort of, different sort of concept than what we had before. And again, sort of educating the perioperative physicians, making them understand the importance of administering multimodal systemic analgesics before the complete resolution of the block. So it is just that holistic management of pain in terms of not just focusing on the block, but making sure that everything else is covered in addition to the block to ensure that it becomes a successful block. And this is sort of further reinforced by the consensus statement by the Association and the British Pain Society in 2024, where they sort of give us a sort of prescriptive list of effective analgesics that are opioid sparing. And they sort of stress in not just those sort of basic pain medications that we normally administer. So in addition to your paracetamol, make sure that you're giving a non-steroidal. Think about alpha-2 agonists. Think about NMDA receptor antagonists like ketamine and magnesium, which are synergistic. A low dose of ketamine has got that role in reducing hyperalgesia. Thinking about your gabapentinoids, again, which are effective in reducing hyperalgesia. They talk about lignocaine, which is useful in abdominal surgery, but sort of, mention precautions about local anesthetic toxicity. So it's all about thinking about not just the normal block and the normal analgesics, but thinking about a lot more sort of systemic, so no opioid-sparing medications that you can add in. So when you think about those sort of, perineural adjuncts that you're going to use to prolong your regional anesthetic, perineural adrenaline has been around for a long time, and it is a vasoconstrictor, so reduces that release of the local anesthetic, but that in turn could be the reason why it's neurotoxic. Perineural buprenorphine, again, sort of acts by stopping the generation of those action potentials and prolongs your regional anesthetic block for a long time. But it's got those opioid-related side effects, so probably not palatable for your day surgery patient. When you think about perineural magnesium, again, that sort of similar mechanism of action in terms of inhibiting your action potentials, but it does prolong your analgesia. The only thing is there is inconsistent evidence about the neurotoxicity, so not sure whether it's good perineurally. When you think about other perineural drugs, you've got your alpha-2 agonists, so you've got clonidine, dexmedetomidine. Dexmedetomidine sort of having a longer analgesic effect, with similar mechanisms of action where it sort of maintains your A delta and C fibers in a hyperpolarized state and therefore inhibits that generation of action potentials again. The side effects are the thing that is not great in your sort of day surgery patient who's going to go home, because the bradycardia, hypotension might stop them from going home, which is more profound in dexmedetomidine because of it's got 8 times more of an alpha-2 agonist effect. Liposomal bupivacaine, again, since the SPARK 2022 study, which shows that there isn't that big a difference between the liposomal bupivacaine and normal bupivacaine to justify the cost, it is not got any license to be used in the UK. And then there is that very limited evidence about the other drugs like midazolam, fentanyl, morphine. Again, not enough evidence to substantiate their use perineurally. So the one medication which has actually made a difference is dexamethasone. So there are multiple systematic reviews, meta-analyses of RCTs, which sort of say that there is low-level evidence that dexamethasone does work as an agent in prolonging regional anesthetic analgesic effect. So the first BJA article is about comparison of intravenous versus perineural, and they go on to say that even though the perineural effect is probably about 2 hours longer than the intravenous, there isn't justification to allow that usage because it is still off-label, don't know enough about the neurotoxic effects, and there is the risk of crystallization with local anesthetics like ropivacaine. So they advocate the use of IV dexamethasone. So the other two sort of systematic reviews is about that dosage of dexamethasone and its effect in rebound pain prevention. And by a moderate level of evidence, they do say that it does have a role in reducing rebound pain. In fact, in reducing the intensity of rebound pain, the time of onset, and that sort of incidence of rebound pain. It improves patient satisfaction in that sense and also improves that sleep outcome. So allows your patient to go home. That dosage that is recommended is that sort of intermediate dosage, so that 0.1 to 0.2 milligrams per kilo. And at that dose, they do say that even though there is a transient increase in blood sugar levels, it doesn't have a long-term effect. And in fact, the British Pain Society does sort of suggest that usage of dexamethasone in patients who have got well-controlled diabetes is not bad, and it is actually useful. Again, that risk of infection is not too high, and there was no sort of evidence of any risk of infection in this sort of study group where this systematic review was carried out. And the reason they say dexamethasone is good is because it prevents that hyperalgesia. It's got that anti-inflammatory effect. And it also sort of reduces that hyperexcitability of your C fibers. So it just stops that pain transmission and reduces that perception of pain. But when it comes to the gold standard of prolonging regional anesthesia, it is your peripheral nerve catheters, because it allows titration of your sensory dose of local anesthetic. So allows your patient to move around, allows them to undertake enhanced recovery pathways, and it is of proven benefit that it reduces your opioid consumption and therefore your opioid-related side effects. The only sort of limiting factor with those sort of peripheral nerve catheters is that it requires skilled anesthetists, it requires sort of further education training of the staff on the ward, and it might sometimes stop the patients from going home unless there is that sort of community backup and support and education which allows the patient to stay at home with those continuous infusion peripheral nerve catheters. So in terms of all the things that we talked about, I think the most important will be your dexamethasone and peripheral nerve catheters in terms of prolonging your regional anesthetic blocks. So to summarize, regional anesthesia is good for your patient because it has advantages for the patient and the healthcare organization. But it is important to remember that about 50% of those patients might have rebound pain. So thinking about what can be done to educate and sort of manage those patient expectations from that first visit in that preoperative clinic to prepare them for that rebound pain. And thinking about, in that sense, the other things that can be done to prevent that or to reduce the intensity of that, like multimodal analgesia, intravenous DEX, and nerve catheters. Thank you.
Thank you, Gina. So we'll ask the questions at the end of the session. And it is always something everybody asks, how can I prolong the regional anesthesia? So it's a great pleasure to invite our next speaker, who is one of our colleagues here, so which is always a happy news as well, Dr. Jyoti Shinde. She is anesthetist as well as a chronic pain specialist. She has also done both extra exams, so extra diploma in pain medicine and extra diploma in regional anesthesia. Currently, she is practicing here as a chronic pain consultant, and she is going to talk about the neuromodulatory techniques that we use in chronic pain. How can we bring that into our acute pain world? So just as soon as she is ready, we will start. All yours. Thank you, Jyoti.
Thank you, Atma, for the wonderful introduction. And thank you for everyone to be here. And it's a pleasure to present about something from the chronic pain. So talking about neuromodulation, it has ancient roots with a very modern technology-driven history. In early civilizations, electric fish was used to relieve pain. Recognizing that control electricity would alter sensations, and this was much before even the neural mechanisms or neural pathways were very well understood. And then the modern era began in 1960 when Melzack and Walsh introduced the gate control theory. And ever since then, neuromodulation in the pain management has gained very much popularity, and it has become a buzzword, a new buzzword even in acute pain field. So as Atma mentioned previously, that there are different types of neuromodulation which can be done pharmacological, non-pharmacological, TENS machine. Today we are going to talk about, I'm going to take in next 15 minutes about what can we take or what can we learn from the chronic pain management. So in next 15 minutes, we can see, we are going to go through the definition. There are different types, the different methods, little bit about gate control theory and about the peripheral nerve stimulator. Before going ahead, I want you all to go through the pain pathways because this is very important, which shows that the pain stimulus goes from the peripheral nociceptors, it goes to the brain, it is perceived by the brain as pain, and then on the right-hand side, you can see in blue is the descending modulation, where we can play with the neuromodulation, and I will come in detail about that in my next slides. So by definition, neuromodulation is a therapeutic alteration of nerve activity by delivering specific stimulus, such as it could be electrical stimulus or chemical agents such as local anesthetics and the steroids and other adjunctives which we used routinely to targeted areas of the nervous system. And the goal is to change the function and performance of the nervous system to treat a variety of disorders and relieve symptoms. So it's not just about the pain management, but it has been applied in other specialties as well. So this is the definition in depth about the International Neuromodulation Society. And in clinical practice, the therapeutic neuromodulation has been the mainstay of acute pain management in the form of regional anesthesia, which we had been practicing all of us, and using local anesthetic and steroids, whereas the use of electricity with peripheral nerve stimulation has been commonly employed in chronic pain management for decades. And also the clinical use of electrical, magnetic, or chemical stimulation to alter abnormal activity and relieve symptoms. It has been used, and it is different methods such as invasive methods like spinal cord stimulator, deep brain stimulator, and there are certain non-invasive methods which has been prescribed to the chronic pain patient is one of these TENS machine or transmagnetic transcranial stimulation or vagal nerve stimulation. It has also been applied in other conditions other than chronic pain management such as epilepsy, depression, or some motion related disorders such as in Parkinson's disease, and the aim is to improve function and quality of life. How does it act? Is by inhibiting the pain signals from, so now we are going to talk only in terms of pain management. I didn't inhibit the pain signals from reaching the brain. It restores function where now signals are absent or sometimes they are impaired, and it also modulates abnormal neural circuit behavior caused by the disease process. So Gina has already mentioned about this type of neuromodulation, which has been routinely practiced by many of the anesthetists with the continuous catheter-based techniques. So this involves a catheter which is inserted and localized targeted nerves or plexus where it has been infused continuously. So I'm not going to talk much about this as it has been already explained by Gina. Now, before going further, I'm going to take you through the journey of neuromodulation. Again, before we understand what is gate control theory, knowing the pain management, this pathway, it is very, very important. You have to understand different medications which acts at different levels, and especially the right-sided descending inhibitory modulation, where all the neuromodulation techniques can be used, and that's where the gate control theory applies. So this slide shows about the gate control theory of the pain. On the top in blue are the C fibers and the A delta and C fibers which transmits pain from the periphery, and on the below you can see in purple is the A beta fibers. They are the large fibers which transmit mechanical stimulus impulse, and in red in between are the interneurons which are present in the spinal cord which controls the gate, and that's where pain shows that pain isn't just a direct signal, but it is modulated at a gate which is in the spinal cord where non-painful input such as rubbing or an injury can close the gate, blocking the pain signals from reaching the brain. In contrast, other than the gate control theory, there are certain psychological factors such as stress or attention, and the intensity of pain signal itself can open or close the gate, allowing the brain to influence pain perception, and that is the reason the pain perception or the pain threshold is different for each individual. Now coming to the main different types of, as I said, neuromodulation, one was catheter-based. This is peripheral nerve stimulator. It is a type of neuromodulation via percutaneous peripheral nerve stimulation for acute pain management. It has been used in chronic pain, but now the new theory has been established in acute pain as well. So it again applies, the theory is again the gate control theory where A beta fibers peripherally increases the action of inhibitory interneurons which are present in the spinal cord, and thus reduces the transmission of pain signals from A delta and C fibers to the second and third order neuron. This is a fantastic study. It's a case series, and it is about the percutaneous analgesic device enabling both local anesthetic delivery and electrical neuromodulation. So what they have used, it's not just a catheter which just stimulates, but it is a catheter which has been used even to deliver the local anesthetic. Either we can give bolus or we can give continuous infusion. It was published in RAPM journal in 2025. So what they have done is that there is a peripheral nerve stimulator which has been already approved by the US Food and Drug Administration, widely used in chronic pain world, but it costs several thousands, and that's the reason there are limitations to implement this in the acute pain management settings. So that's the reason now there is current solution which has been under the investigation for post-operative analgesia, and that's called as relay system, which is a novel device which is designed to integrate both local anesthetic delivery and PNS. So it has a dual mechanism. The traditional catheter over the needle device, which allows injection of local anesthetic and also infusion through that. So this is the needle which has been the relay system. You can see here that it has an integrated impulse generator, and proximal end it shows the electrodes through which we can do the peripheral nerve stimulation. And 4 centimeter proximally, you can see there are projections which has been, there are the projections which you can see there. They are the projection, you can call it as tines. They are 70 to 90 degrees to the needle, so which is helped to prevent it from dislodgement, because that's what commonly we had been seeing, that peripheral nerve catheters are easily dislodged. So they have come up with this thing which will prevent the dislodgement. These needles are present in different sizes and different gauge. It incorporates the embedded wire and integrated pulse generator, which I have shown in the previous picture. And this can be kept, and peripheral nerve stimulation can be done for almost 28 days. Each catheter has 3 electrodes, as it was seen in the picture, and which may be programmed as anode or cathode. There are, as I said, the proximal, the small projections. So when we insert the needle at the catheter, if you rotate it counterclockwise, these projections are 70 to 90 degrees, so that prevents it from coming out. And when you want to remove, you have to rotate it clockwise so that the projections flush across the catheter and you can remove it easily. This is the picture where they have used this system for the interscalene nerve stimulation, and you can see that how it is fixed, and this patient was sent home and he received peripheral nerve stimulation post-operatively. Now the impulse generator can be connected via Bluetooth to the telephone, to the patient's phone, and it has been using a proprietary application by the company rep. Then minimum and maximum currents which were set were 0.2 milliamperes and 10 milliampere respectively. And this catheter has separate electrodes. As I said, that one was anode and cathode, and then the other one, the proximal one, was inactive. This is another study which was published in RAPM journal, was the role of neuromodulation in acute pain settings. So in this picture, you can see that they have compared this neurostimulation system in 2 settings. On the left-hand side is the chronic pain system, and the right is the peripheral, regional peripheral catheter system. The difference between 2 is that in chronic pain, they have inserted the catheter and kept 0.5 to 2 centimeters away from the target now, whereas in the acute pain settings, it was closed in close proximity to the nerve, and also the settings were different. In chronic pain, the frequency was very high, that was 100 hertz, and in peripheral catheter system, it was low frequency and low current. And how does it act? Again, the mechanism of action depends on the gate control theory by stimulating the larger fibers, and that is how the threshold leads to decreased transmission of the pain fibers, transmitting the pain to the brain and reducing the pain perception. In addition to the gate control theory which I had been talking, it also has central pathways and which can be activated and modulated through the peripheral nerve stimulation. And it has also demonstrated that it can modulate endogenous neurotransmitters and affect the plasticity of the NMDA receptors, which are responsible for the sensitization and leading to chronic pain. The effectiveness and safety of PNS not only depends on the characteristic of pain, but it also depends on the electrode tissue interference, where and how far you are keeping it away from the nerve. It depends on variety of physical factors, such as proximity to the nerve bundles, tissue characteristics, whether monophasic versus biphasic stimulation, what type of stimulation has been used, what type of frequency, and the different waveforms, and the voltage used, all of which needs further investigation and careful consideration, and which is under process. The advantages are that we all have seen that perioperatively there is neuronal injury and neural inflammation which is encountered in the post-operative period, and this contributes to the chronic post-surgical pain development through various mechanisms, including priming of the sympathetic nerves. And the advantage of neurostimulation is that it And that's the reason, one of the main reasons for increased interest in PNS is potential to modulate the pain signaling and decreases neuronal sensitization, and thus reduces the incidence of hyperalgesia, allodynia, and severity of neuropathic pain during the period of post-operative period, where the pain intensity is at its highest and reducing its persistence. And the option of prolonged application of PNS for weeks to months is advantageous compared to local anesthetic nerve blocks, because PNS is usually not associated with motor blockade with its attendant risk, such as reduced mobility or the risk of falls and delayed rehabilitation. Now, these are two different, I'm going to present about some of the articles in the real world where they have collected data. It's a cross-sectional follow-up survey where the patients had stimulator and they were stimulated for 60 days. And this is the system which has been approved by FDA and it has been used in chronic pain setup. And they're trying to see if this can be implemented in acute pain settings as well. Now, these are the two articles which are being published in RAPM journal by our own Atma, and she has already mentioned about it, how she uses it and what are the settings. And we are lucky to have her here so that we can go through more details and get more and more information. These are some of the references. So take-home messages. Peripheral nerve stimulator is a novel technique, and it needs more of the research in that. It delivers small electrical pulses near a peripheral nerve to reduce pain. And modern percutaneous nerve stimulation is a minimally invasive opioid-sparing option for carefully selected acute and transitional pain services. Thank you.
Thank you, Jyoti. Again, future is bright. It may still sound a little bit alien to many regional anesthesia specialists, but trust me, neuromodulation is coming. So we need to think about that. So our next speaker is Mr. Ali Mehdi, who is our medical director at the Kent and Canterbury site, who is going to talk about the human factors, which is so important, and team building for success of regional anesthesia programs. Unfortunately, he is not able to join us in person because he has got some medical emergency that he needs to attend. So he has sent the video recording for us, and we will listen to the recording now. I will change that. Yeah, this one.
So we'll see me as well. It was a bit informal. I apologize.
So it had been recorded earlier, but due to transmission difficulties, I'm doing it again in the comfort of my home. I'll be at the dentist when you will be listening to this talk. But I'd like to extend, as the medical director of Kent and Canterbury Hospital, I'd like to extend a really, really big welcome to everyone, especially guests who have come from outside Canterbury to attend this fantastic program on the World Day of Regional Anesthesia and Pain Medicine. Is a good program put on by Dr. Thothungal and Dr. Nenadic, and I'd like to make the best of it. Whilst there are technical skills that are going to be discussed throughout the program, I'm really keen that we pay some attention to human factors or non-technical skills that can shape performance of these drugs or of these blocks. Now, it has to be appreciated that we have systems in place to make sure that we avoid errors. So the WHO checklist was started in 2009, and that showed a clear decline in complications and mortality. However, a study in 2010 by the Safe Anesthesia Liaison Group found that 67 wrong-sided blocks were reported over a 15-month period across NHS England. And in response to that, Stop Before You Block was started to make sure that the right patient was getting the right procedure on the correct side, right block, and correct imaging was being used, and the consent matched the plan, and the marking was absolutely visible and unambiguous. So we also had a program of national safety standards for interventional procedures since 2015, modified further in 2023. So you can see on the right of your picture, there is a regional pain blocks outside theatre. that are prep, stop, block, and checklist. Some of you may be familiar with it, but if you aren't, then this is a standard checklist for doing a block. Despite those measures, even now, approximately 10% of never events are wrong-sided blocks. So the prevalence hasn't decreased. Very often it's brachial plexus blockers or femoral blockers. There's still variations across different trusts and different standards, different environments within trusts as well. So what are the errors that commonly happen? It's misidentification of site. So for example, somebody with a broken hip comes into ED, their leg's not marked, and then they have cognitive impairment, decreased mental capacity. You will find that a mistake's made. Confirmation bias. You believe that you're doing the right thing. You don't want to believe anything else. You believe that, you know, the drug cupboard has the same stock of medicines and nothing's been changed around. That could be a problem. So it's about confirmation bias. Not following the checklist, which we mentioned earlier, and most importantly, interruptions and distractions. So some of you working in the emergency department in that environment will find that there's constant noise, you being disturbed, you being pulled, shoved, whatever. And we'll talk about the sterile cockpit in that. But remember, a lot of us are fatigued. We are hungry, angry, late, tired. There may be some training gaps, not just with us, but also with colleagues. Communication gaps. Very often we assume, even with checklists, we assume that we're doing the right thing. But with checklists, I can tell you as a surgeon, sometimes people aren't paying full attention. Their mind is somewhere else. Sometimes the language being pronounced, the accent could be different. People are just mumbling and rushing through things and attention isn't being paid. Full mindfulness isn't there. So there's that gap in communication. Sometimes there are semantic variations where injection block, things like that can be mistaken. So we have to be very clear in our communication. So human factors are organizational, cognitive, and physical elements that shape performance. So cognitive element is about our brain, in our brain's perception, but also the perception of what we are saying to others. And like I said, it is affected. The working memory is affected by being hungry, angry, late, tired, all these things. Civility saves lives, remember that. Physical environment, where you've got light issues, you've got cramping, you've got supplies everywhere, here, there, everywhere, and different places. Those can affect things, but also not having correct safety procedures in place from an organization and the wrong culture, a culture of hierarchy. Not being able to speak up safely is a problem, but these things do matter. So we talked about how hungry, angry, late, tired impacts the brain, but also about situational influences. It's important to understand that when you're rushed, when there's an emergency, you have, you know, people in corridors, you have people in theater lined up, you have a long list that can impact. So are there systems that actually help to structure human factors to improve performance? Yes. So the ANT system, the anaesthetist non-technical skills, very similar to non-technical skills for surgeons, is about task management. So you prepare. Otherwise, if you fail to prepare, you prepare to fail. So you need to have that sort of task management, but also you need to be able to communicate to your team all the activities that you want to coordinate. So communication is important, decision making, and being situationally aware. So if you don't have the right cognitive conditions, if you don't have the right space and organizational conditions, knowing the impact of that is important. So very often airline pilots, they work with different teams. It's not the same team, but having that common, that very, very common approach reduces error. So it's about breaking down hierarchy, speaking up. If somebody is pointing out that there is likely to be error, yeah, take it. It could be the junior-most member of staff. Having S-bars, but most importantly, checklists. So checklists have been shown to minimize error, but checklists, again, have to be run with the right cognitive approach. Being switched off when a checklist is going on or just rambling through a checklist, no, that doesn't work. So we talked about, you know, the environment. Absolutely, it's important to have good workflow. Briefly again, making sure that you manage your workload in an ergonomic setup is very important. Repeated training has been shown human factors, embedded training for doing technical skills has been shown to reduce error. And I would strongly encourage that you build in an element of that in your workshops this evening. The sterile cockpit, it has been shown in aviation that at certain critical points, you want absolutely no contact, no disturbance. So, for example, a surgeon walking into the anesthetic room when you're doing a block, it's an absolute no. Playing music, having all sorts of chat, shifts changing, change of order of lists, all these things absolutely should not happen in the anesthetic room, particularly when an invasive procedure is happening. My recommendations, it is important to be extra vigilant when there are delays between the sign-in and the block, and that is the new stop before you block condition. It should be within 30 minutes of the sign-in, because a lot of errors were happening because there was a prolonged delay between the sign-in and the actual blocks. Be careful, when the patient's been turned over, right becomes left. The surgical mark may not be visible or actually isn't there. So I think it's critical in the emergency environment, particularly that I know of, a wrong-sided femoral block in the last 2 years that I had to deal with that incident. There's no marking. So performing lower limb blocks, these are ones at greater risk, and working with different staff members, particularly the inexperienced staff. Always double check the surgical mark block side. I'll leave you with this case-based scenario with Dr. Nardic or Dr. Thuthungal. We'll discuss, they've got the notes, and I'd like you to reflect on the discussion that we've just had. I'd like you to have a really good day, and I'm sorry again that I couldn't join you. Take care, bye-bye.
So, due to time pressures, we'll move to next session. That's why we need a block room.
Also, we will have the discussions at the end of the next session while we prep for the live scanning. Is that okay? So that we can get on. Yeah?
So, today on this World Day of Anesthesia and Pain Medicine, we recognize that regional anesthesia extends far beyond operating theater. It became a key tool in delivering safe, timely, and efficient pain relief across acute care settings. So this session, regional anesthesia beyond operating theaters, is focusing on the growing role of regional anesthesia in ITU and emergency medicine. So it's my pleasure to introduce Dr. Giuliani, a senior emergency medicine consultant at William Harvey Hospital and clinical associate director for medical education. He has an impressive teaching portfolio from emergency medicine faculty lead roles to college tutor for emergency medicine, and in keeping with this presentation, he has an special interest in emergency ultrasound and echocardiography. So today, he will share his perspective on regional anesthesia in the emergency settings. Mr. Giuliani.
Is it working? Okay, so before I came in here, Atma just tapped my shoulder and said, I'll give you 2 minutes. Is that what you said?
No, 2 minutes warning.
Okay. But I'm good, but I'm not that good. Anyway, so thank you, Atma, for clarifying that. So I know it's me and Ritu, who just the two people holding you before lunch. So we've taken an executive decision to make it brief so that you don't go to sleep before lunch. So first of all, so can I ask you how many people in the audience are not anesthetists? I know a few. Right, so I think 5 or 6 or 8 maximum. So what I'm going to do for the next 5 minutes is take a bit of dig on my colleagues from anesthetics. So it's either foolhardy or brave, but okay. So the reason for this is I've been a consultant for nearly 10 years now. And there come times in life when you think, look, the job sucks, it's hard, we get slated in the media and everywhere else. But there are times when you feel, no, this is something worthwhile. And being able to do this has been one of the most gratifying things I've done in my life. I mean that, and I will tell you a story which will kind of emphasize that point. So the point is, look, we work in ED, so we get a lot of people with trauma. And as it happens, we live in an area which has a lot of elderly people. And what happens to people who are old? I don't know why, they often get up in the night and often go the wrong way to the top of the stairs and invariably fall. So that trauma comes to us not just as trauma, but a whole package, as you can imagine. So, next please. So let me take you to the story. It's a true case which happened in July last year. Okay, yeah. So this is a chap who's 93 years old, and some of my colleagues might recognize the case. He came in, like I said, he was doing this. He fell downstairs, and as it happens, couldn't ask for help right away, and was lying on the floor for 12 hours, which is not unusual, happens a lot. And so he came in, I just want to make it quick. So he came in and, like everybody else, had a trauma CT scan, and this is what he had. So 6 to 9 fractures, but not only fractures, he had a flail segment, and sternal fracture, a hematoma, a pneumothorax, a surgical emphysema, and a moderate left effusion, which obviously didn't help his breathing. So bilateral subdural hygromas, fracture of a scapula, and spinal fractures from C4 to T1. I don't know how he did that. He broke all his spinous processes from C4 to T1 level. So, as shouldn't come no surprise, every DOAC these days, so likewise, he has CKD3, AF, he's in a lot of pain, he's a bit agitated. So this is my typical patient. So in old days, what will happen to these patients, get them opiates, oxygen, and a lot of optimism, okay? And the trouble is, it hurts when you breathe, right? It hurts when you cough, and it hurts even when you think you're going to breathe, right? And we all know these patients, if they don't ventilate, they'll get a pneumonia and they'll die. So look at his injury. So can you see that pneumothorax at the top? And does it point or not? No. And these are not just minimal fractures, quite significant displacement. And you can see that segment at the top. So he has, unfortunately, both posterior fractures, anterolateral fractures, a flail segment, and I don't know if you can see those fractures. They're quite brutal. So what he had, the choices were, in old days, I think a few years back, would have been to call the anesthetic colleagues, whom I love, all of my friends here, anesthetics. So the trouble is, what they want is what Ali said, a sterile cockpit, don't you? And you want a patient who's calm, is not bleeding, is not on a DOAC, has no CKD, and then you come in a minibus with an ODP, a core trainee, and a consultant, and then the next is, where's my anesthetic room, right? That doesn't happen in my ED, right? Have you been to any ED these days, right? So we are called, sorry, I hope this doesn't go any further, Costa plus or Costa negative. So even our Costa sometimes with patients, which was in the media also. So that's where I work. So the choices were those. So I think the great thing is, this patient had 2 blocks. We gave him a cerebrocentric block because he had anterior fractures and ESP block. And then proceeded to have a chest drain. And he was okay, but I didn't know. But I was worried about him. He's 93. We all know what happens with people. The risk of getting a pneumonia and obviously not being able to ventilate means it's almost a certain fatality. So I went to see him the next day on King's B ward. And this chap was sitting in a chair having a cup of coffee. And I swear to you, that one was the best moments of my entire career. It was such a gratifying with his family, and his only complaint, I swear to God, was he could not have restful sleep. That was the only complaint he had. So I checked on him, because I knew I was going to present at some point in my life, and I called him a month later. He's still under respiratory and all that, but he's back to his life, his real life. The only thing he doesn't do now, he doesn't drive a car, but he's back in this family. It was such an amazing story. So that's one. The other story, which is probably not related to anesthetics, is more about human factors and having a growth mindset. I'm a kind of a fairly senior consultant, but I was taught these blocks by my registrar, Salman. So this bugger was really good. He came in as an ST5, was very passionate about blocks. I learned from him. He went on to Australia now, but it's such a great legacy he's left for us. Now I'm teaching on these blocks and so forth. So you're never too old to learn. Two is never have any egos and always acknowledge people who leave a good legacy. So I'm going to name him again. His name is Salman. Wonderful. He was my trainee right from his core trainee days, but left a great legacy. That's also important. So I won't bore you with the theory or the trials, etc., and so forth. There is evidence. There are lots of RCTs and systemic reviews, but not massive amount of evidence. But I'm telling you what I see on a day-to-day basis, and I'm so glad we're one of the few EDs where the ED staff do their own blocks. Not all of us, but I think 40% of us. There are 4 registrars here, and all of them do blocks. In fact, Anita told me she did one yesterday. It was fantastic. So we all know, some of us know that, the best things about these are, our patients have lots of comorbidities, and majority are on DOACs, might have other medical issues and all that. So this will reduce your opiate use, and you get much better pain relief. You get improved respiratory mechanics and better diaphragm excursions. And most importantly, you don't have to rely on epidurals and all that, which are all time consuming. So less risk of delirium, and they are fairly easy to teach. If I could do them, I'm sure all of you can do them, right? And especially the center block is a very, very easy block to learn. They're very effective. We've seen them, and it also means these patients don't need to be on opiates. And we have seen a couple of SIs when people CKD3 had opiates, and earlier on when the pain was keeping them awake, when the pain was relieved, they went on to have respiratory depression, and sadly one patient died. So less risk of complications. Having said that, we had our first patient of last. It was a patient who came from One Ashford, had an epigastric hernia done with some infiltration anesthetic, and came in with a proper last. And we had to empty all our intraoperative store, but that patient came around. So please don't do them ED unless you know the last policy. We have that as a laminate on our blocks trolley. Obviously, for AD, I know we sometimes a bit cowboys and cavalier. It's very important to be sterile, because this is no different to an epidural, because how the block works. So I'm making sure that our staff always prep properly, wear a mask and fully gowned, etc. So we'll talk about this when we do the demos. So we know ASP blocks covers your posterior fractures, and can also be used for TP process fractures, and can be even used for, for example, if somebody has bad pancreatitis pain or zoster pain and pancreatitis. I would personally use a curvilinear probe for 2 minutes. And I think personally I find the best way to do it is prone, but it's not always practical. And once again, from ED perspective, we have so many distractions, very important to mark. The trouble is sometimes when you change position, you might forget what is right and left. So simple things matter. I'm just going to rush because it's probably a bit more for practical use. Serratus anterior block, anterior fractures, very easy to perform. And as I said, probably better to talk about them when we do the actual sessions. Once again, talks about volume. So these are volume blocks, and we use levocaine, and some trusts use ropivacaine. So the key takeaways for us are they are comparable to epidurals, and I've seen them. We know we have that little experience and less complications, and they are feasible, as we have demonstrated to be done by non-anesthetic colleagues with the right training, support, and doing them the right way. And also, you know, the one great thing is then you don't have to ask for colleagues to come out when they're busy watching their Sky TV. Thank you all.
Thank you very much, Dr. Giuliani. So our next speaker is our dear friend and colleague, a senior consultant anesthetist in intensivist, Dr. Ritu Kapoor. We work together at Kent and Canterbury Hospital. She's a primary FRCA examiner. She's a medical examiner. She has extensive academic portfolio with multiple publications, including critical care textbook. So her interests include anesthesia and head and neck surgery, medical education and training, and the medical legal aspects of medicine.
This is really testing my abilities today. Right, guys, I'm not going to ask the same question that Saeed's already asked. If there are so many people who are not even anesthetists, I'm going to take it for granted that there's no intensivist here. Would I be right in assuming that? Probably am. So I'm actually going to talk to you about regional blocks in intensive care. You wonder why. The thing is, pain is common in intensive care. Pain is common everywhere. It is ubiquitous. It's not benign. We've had enough talks today categorically stating it's not benign. This isn't controversial, is it? What we see is everything we do in intensive care triggers pain, and it has a consequence. I'm sure everybody would agree with that. So just sorting out pain in intensive care is not about comfort. It is about outcome. And this is the reason why you need to ensure that your outcomes are good, purely because you can have pain right up until 24 months. This is our data. This is UK data. What are we doing about this? Why do we not sort pain out in intensive care? This is the uncomfortable bit. ICU patients are clearly worse. They're sicker, they're frailer, they're more opioid sensitive. And then what do we do for them? We give them more systemic opioids. I'm sure anybody who works in intensive care will identify with that. Yes? So the question I want to explore today isn't about regional anesthesia working. We've had enough talks telling us regional anesthesia works. The question I want to answer is, why hasn't it taken off in intensive care? It's a thought, isn't it? We are very precise with noradrenaline in ITU. Yes, every 0.01 microgram per kilo going up makes us sit up and take notice. But when the opioid goes to double the dose, it's an eyelid. So what has regional anesthesia got to offer us in ITU? Basically, these are the patients that probably would benefit the most, way more than your peri-op patients. Yeah? We'll get everything we want, and it clearly makes sense physiologically. So why does regional anesthesia work wonderfully in peri-op? Anybody wants to hazard a guess? It's because there's ownership and there's systems in place. It's anesthetist-led. I know Saeed just talked about ED, but at the end of the day, it's the anesthetist that started it, made sure there was individuals that could actually deliver this. Analgesia is planned. It's not reactive. All of you tell your patients about the analgesia they're going to get post-operatively. It is embedded in anesthetic practice. It is therefore very important that we compare this to intensive care. So why is intensive care different? It's not peri-op care in a noisier environment. The physiology is unstable, the assessment is harder, the ownership is shared. I don't need my surgeon to come and tell me what to do, but they do. Analgesia competes. It doesn't, rather than supports patient care. It's constantly competing. It's a case of, do I want to start RRT? Do I want to give more noradrenaline? Do I want to give analgesia? What's going to be my priorities here? So these are the reasons why RA works brilliantly perioperatively, but precisely why it struggles in intensive care. The barriers are real, and it's very important that we acknowledge it. Despite the theoretical benefits, regional anesthesia isn't embedded. I'm not aware of anywhere that this is fully embedded. And that's not because people don't care. I've got enough of my colleagues coming and telling me we need to do this. We need to make sure the pain is controlled. Despite that, it is not prioritized. It is primarily because of everything that we compete, and we are constantly playing a balancing act. And in that balancing act, it becomes a systems issue, not an individual failure. Why has it lagged behind? Because peri-op care success is measured in hours, maybe days. Pain control in intensive care is measured in days, weeks, months, years. We are not a patient group of people. We therefore need to think and decide what is it that we want to prioritize. By and large, we prioritize what can be measured easily. My NORAD dose, the blood pressure, the heart rate, the urine output. Measuring pain is hard work. There are blocks, and I'm not going to go through it. I've got lots of experts here to tell you what blocks you can do. All I'm trying to say with this slide is that there are plenty of blocks that are suitable for intensive care. It's just something that we need to think about. The best ICU block is the one that reduces harm without adding risk. ITU is very risk averse. So what do we need to change? This isn't about every intensivist becoming a regional anesthetist, as I keep trying to tell my colleagues. It is about recognizing analgesia is core to intensive care. It should be one of our core principles. It's not an optional extra. The biggest gains will come from shared ownership, absolutely. It will also come from thoughtful selection of patients, probably not every patient. And it will also come through better integration with intensive care practice. What we need is a systems change and not just the skills to deliver. So what does the future hold for us? The future is bright. We've already realized that. There's lots of people that told us what we're going to do next, with neuromodulation and everything making a move. It's all about doing things better for the right patients. And let's not forget, AI is it's waiting to come in. It's going to be AI-assisted imaging, and once that comes, you don't need to be an expert. You've got AI to tell you what to do. Regional anesthesia is evolving, and we're all waiting to go down the road where it becomes an integral component, multimodal, opioid-sparing pain management. It'll be driven by the advancements that are made in the techniques. So coming to my last slide, I know I'm keeping everybody away from their live demonstrations and their lunch. Regional anesthesia won't replace opioids in ICU, and that's not what I'm here to tell you. I'm here to tell you that it doesn't need to. What we need thoughtful use, and has the potential to reduce harm and use it in our patient population that are uniquely vulnerable. The real question that I have for all of you isn't whether we can do this. It is, why haven't we fully embraced it? Thank you.
So, thank you much. Thank you very much, Ritu. So that brings us to the end of our morning sessions. So we have a little time for questions about these 2 sessions. Yeah. And all the faculties, please, for the all the speakers from the last.
Thank you so much. Very interesting. About our A&E colleague, I just have to say it's not a Sky TV, it's usually Sudoku that we are doing. And I have a question about the buprenorphine. That had one of the longest effects in the slide you have. How we are giving it, that wasn't anything in there. Oral, IV, buprenorphine.
Suggest that it is not neurotoxic, and the reason it does have the longest sort of duration of analgesia, but the reason it hasn't picked up that much, in addition to the fact that there is no definite evidence about the neurotoxicity, is about those opioid-related side effects. So your nausea and vomiting is much higher, pruritus is much higher. So all of those things, from a patient perspective, is not actually very palatable or very nice. So that nausea, vomiting was the main. No, perineural buprenorphine is there. Yeah. But not widely used and not encouraged to use. Thank you.
Thank you, Dr. Kapoor. That was fantastic. Regional anesthesia intensive care. I have thought about it over decades and haven't had a question. Have you ever thought of integrating the concept in the critical care nursing curriculum?
I think you're quite right. It does need to be integrated in the curriculum, because if you start it when they're younger, you can actually use it. I think before it gets into the curriculum, it needs to become part of care bundles. It's at the moment not part of the care bundle. And actually making it part of that is going to be the stepping stone before we can. We are a long way off getting there. But if people are interested, we can potentially get there.
Hi, my question is about prolonging the duration of regional analgesia. You were talking about dexamethasone. Can we do audits by adding dexamethasone in various blocks, or is it not allowed in Britain or UK?
Thank you. So in the slide that I showed, one of the first sort of studies that was done in BJA was a systematic review where they compared perineural dexamethasone with IV. And their ultimate recommendation is to go with IV. So in that, they did 4 milligrams of perineural dexamethasone versus 8 milligrams of IV dexamethasone. And they showed that there wasn't that big a difference. The difference was just 2 hours. So perineural dexamethasone is off license. It can't be used with ropivacaine because it crystallizes. So what they did was sequential administration. So you do the ropivacaine, then you administer the dexamethasone after, and there's always that risk of crystallization inside the body. So because the difference is only 2 hours, what they're saying is go with IV, but a higher dose of the IV. Thank you.
Just because I'm using it a lot as well, just one note, give it slowly. Because with the bolus, it's really unpleasant perineal sensation. So I always give it in like 100 ml of normal saline over 10-15 minutes, and it works really well. Yeah.
Just to add to that as well, if you are using perineural at any time, it has to be preservative-free, okay? Not the preservative one. Yeah, we can get it preservative-free, but remember, if it is pure perineural, it has to be preservative-free. Yeah, IV can be with the preservative or without preservative. That is because with the preservative it is cheaper. That is why the IV is cheaper. But if you are going for perineural, purely perineural, because we use it for the central neuraxial blocks as well in chronic pain, it has to be preservative free. Yeah, no, it is, there are one company which needs to be in the fridge, the other company you can keep it like a normal in the cupboard as well.
Yeah, so for chronic pain, we are using dexamethasone, which is preservative-free, so we tend to use it preservative-free, and it's kept out of the fridge. One more thing I would like to add, it's one of my experience in ICU. So one of the patient during COVID time was in ARDS and was prone for a long time and prolonged admission in ICU, probably more than 2 months. And patient complained of pain, and then we were involved, obviously, because they had increased opioids, nothing was working. And that was really a good case, because when we went and saw, I was the one who attended. Patient has classic presentation of meralgia paresthetica because of the prone position. And I just went and did ultrasound-guided lateral femoral cutaneous nerve block and had wonderful pain relief. And that was something which I think when I saw your lecture, that reminded me that yes, that how regional anesthesia blocks can be useful in the intensive care unit. Thank you.
Any more questions? Otherwise, we can go to the live scanning. There is one more question. Yeah.
Thank you. So this is for Dr. Gilani. Do you recommend using dexamethasone in our AD at all? Because as we know that we don't have the one which is for neuraxial. So do you give it IV?
Look, Anita, you know, we just started. Let's keep it simple.
Yeah, saying that, Said was mentioning about Saman, and he's an amazing guy, even though he's an ED specialist. And also, no, he was very honest to appreciate his trainee triggering that enthusiasm in regional anesthesia. And Salman came to my theater to learn about neuromodulation, even though he's an ED specialist. Even today, we message each other. He asked about what can I do, and we are writing a paper together about a QL blocks for acute low back pain in ED. So thinking outside the box, as you know, all the specialists were talking about intensive care and ED, it is being imaginative about how we can do. And he was so great to acknowledge the fact that, you know, from his conventional method of being an ED physician, somebody came and triggered that passion, and he's taking it forward. So thank you.
Just quickly add, I think, you know, the great thing was when Salman went to Australia, the first thing he said, they don't do blocks here. So, look, at least that's one thing we do better than them. It's not widespread, but I think it's, if it was my family member, I would want them to have their block at the very start. As I said, I'll repeat again, one of the most gratifying things of my entire career. You know, those people used to die. That 9th chap will not survive. You know, you can do an epidural later. You know, it's not easy, very time consuming, and as I said, you know, it has made a big difference to our patients. So please, anybody who's not anesthetics, learn to do them. You will love it.
Thank you all. So we will move on to the live demos. So Ritu, just to introduce while we are setting. So this is transitional pain blocks as a live scanning. We do have facilities and opportunity for you to come and ask questions when we are doing the hands-on workshop in the afternoon, because you will be in your stations as a routine, but the free station is in the middle. So please feel free to come and ask and also get, you know, your hands-on experience, whatever we are doing here today. So I'll leave it to you.
Right, so now we're moving on to the thing that you've been waiting all this while. Our faculty is going to include Atmaja. You've already been hearing her, and I don't think she needs any further introductions. We've already done it twice. And I'm sure most of you would remember everything that has been said. Dr. Zubair is another one of our colleagues from the Trust. He's a consultant anaesthetist and a chronic pain consultant. And together they're going to be doing this. But I think we need to give a big thank you to Alex, who is one of our ODPs. We couldn't work without him in theatre, and we definitely can't work without him here today.
Yes, as I told you, all our models are our own people, so please do give that due respect to them. And Alex is one of our senior ODPs, and he agreed to be the model for today and arranging all the other members as well. So what I'm going to do here is few of the blocks known as chronic pain blocks. You don't normally do it, but you can use it in acute pain situations. And also some of the regional anesthesia blocks that people think, oh, I can't use it, can be used in chronic pain situations as well. I always say pain should be just pain. Don't even divide it as acute chronic cancer pain. Pain is just pain for the patient. So the first one that I'm going to show you is a greater occipital nerve block, okay? So this is normally used in chronic pain headache conditions, but this is one of the most useful technique for PDPH, post-dural puncture headache. You treat them with a normal or analgesic. If it is not working, what is the next big gun? Blood patch. You worry about a few red cells in your epidural catheter, but you are happy to produce an intentional epidural hematoma using 30 to 40 ml of blood. Yeah? So think about that next time. So for the greater occipital, so it is the C2 nerve root coming, which supplies the entire part of the scalp in the posterior region. And also, why it works is the C2 has a communication with the cervicotrigeminal ganglion inside. That is why it works for the headache, all types of headaches. So what you need to do is, I will teach you the cheating method, because that is the easiest everybody is looking for. So you feel the mastoid, yeah, here, where I am pressing here, yeah? You put your probe in there, and you will put your probe slightly in a slanting position. Yeah, we need to increase the gain. Light is it okay to see now? Yeah? Yeah? Decrease, yeah, that's okay. No, we just need to flip the picture there, please. Can we switch off all the lights? Yeah. Okay. Can we have the ultrasound picture in the middle, please? Yeah. No, the ultrasound one. Can we have the, yeah, there you go. So you can see what is sitting on this side is the mastoid here, yeah? You can see the mastoid. And you go slightly medial, you see 2 layers of the muscle. So the most thin one on the top, even above that is the trapezius. That is the trapezius muscle. Then you have the underneath, that slightly thicker one where the marker is, where Mohammed is showing you. That is the splenius capitis muscle. Splenius capitis is like a band across there. Underneath the splenius capitis, you will see a very thick muscle there. Underneath the whole thick muscle, yeah, that is the inferior obliquus capitis muscle. The fascial plane between the two, you can even see like where the dot is actually, you can see sometimes a vessel as well. Okay, you can even see that is your greater occipital nerve and blood vessel. Can you see how simple it is? Yeah? So for a patient with the post-dural puncture headache, especially if the patient is an obstetric patient, yeah, you can just put some local anesthetic from here as a subcutaneous like an infiltration. If you don't have an ultrasound, that will give the headache relief itself. If you have an ultrasound skill like this is what you need to do. They put them on the side, so they don't need to go on their tummy after delivery. Put them on one side. Do it in that fascial plane between the 2 muscles there. Yeah, it is as simple as that. Is that clear? Sorry, volume. 5 ml is plenty. 5 ml. Both sides. So one side, head, turn the head the other way around, do the other side, or sitting up. So in chronic pain, we do like a sit-up and cuddle the pillow like this so that it is all good here. And please don't put steroids in here, because women will lose their hair. Okay? So don't do that. But otherwise, it's a very good block as an intermediate bit, but you manage the patient and look for all the neurological symptoms, everything as usual. But before you take your big gun out of epidural blood patch, this is something that can be easily done in the ward as well. Yeah? So that is greater occipital. 5 ml each side. 5 ml each side. Yeah? That is what. You can give IV dexamethasone though. Yeah? Okay, so the next one.
Sorry, just to add my experience for the obstetric patients. I've done few in the trust, and they have been very successful. And it's a very simple block, as mentioned, and they are quite successful as well. So doing the block, just occipital nerve block, avoids all the risk of having, giving another epidural, and obviously when the patient comes in that situation, it puts you in more challenge because it's a redo procedure and there is more risk of having another puncture. So if we can try things non-invasively, which is less invasive or non-invasive, we should try that first. Even within our chronic pain patients, we had a puncture with a 16 and a 14 gauge needle, which is a bigger, larger gauge epidural needle. Even in those patients, I have tried this occipital nerve block, has worked brilliantly. So just keep in mind, this is one of the simplest block which you can do for your obstetric PDAPH patients as well as any patient who comes with the spinal tap.
Wonderful. So the next one is superior trunk, one of my favorite, because I started using in chronic pain probably almost 2012. Okay, even before it came into acute pain world. And I was doing it with the neuromodulation. And I'm so pleased to see now it is in the acute pain world as well. So we continue in the chronic pain, but acute pain is using in a different form as well. But so I bring the neuromodulation bit as well into my acute pain world. Okay, I have not done a conventional interscalene all these years. Okay, I do only superior trunk. Because C5, C6 is the dermatome, myotome, osteotome, sclerotome, anything that you can think about your shoulder. All 5 nerves will be covered by superior trunk. And it is outside the interscalene groove, the chance of having a phrenic nerve involvement, especially if you are using low volume, is very little. Okay, so the way I use this, so on the left-hand side is the middle and the right side is the lateral. So can we increase the depth, please? Yeah, I always start scanning in the midline. Because if the patient is alive and talking to you, the trachea is there, and that beautiful thyroid. Again, it is not my job to look at the thyroid, but I always scan up and down. I have picked up things that shouldn't be there in at least 3 or 4 patients. It takes only like a couple of seconds to do that. So the first muscle that you see on the left-hand side is the pretracheal muscles, your sternothyroid, stenohyoid, and on the right-hand side is the sternocleidomastoid. You can see the jugular vein, which I'm not compressed enough, and your carotid, and just underneath the jugular and the carotid, there, that you will see the vagus nerve, okay? So once you see that, you go laterally, and you will see that just underneath the sternocleidomastoid, the muscle that you see, that is the posterior valley of omohyoid. This is important for you. I will tell you why in a minute. I'm going to ask Alex to turn his head ever so slightly. This is something that we do for our patients as well, because all the brachial plexus will come forward when you do that, okay? Turn, then the first muscle that comes at the most lateral part of your sternocleidomastoid, that is the scalenus anterior muscle, okay? So go a little bit more lateral, you will see the scalenus medius muscle and the interscalene groove. And this is the area of interest for you. So you start scanning up and down to see the plexus, which coming in and out, because it is so, can we reduce the gain ever so slightly? So reduce the gain, not too much, bit more gain, a little bit more please, so that I can see the, and you can see, yeah, decrease the depth a tiny bit. So in this interscalene groove, you can see the scalenus anterior and the scalenus medius, and the little bubbles scanning in and out. So ideally, which we will show in the area when you are scanning downstairs, how to identify C5, C6, C7. This is very, very important. For the demo, for a quick purposes, I'm just showing the C5 and the C6 at the top. It is coming and joining like a bundle. Can you see that little bundle there? Yeah? Can you see that bundle? So superior trunk is between your interscalene and the supraclavicular. And what is important is at the 1 o'clock position of that bundle, can we reduce the gain tiny bit because it is over white there. Okay, so that particular one which you can see, that bubble there, which is coming off from the 1 o'clock position of that superior trunk, that is your suprascapular nerve. This is where you will block it if you want to do an anterior approach to suprascapular, which we will be showing downstairs when you scan. Okay, in the advanced group. Okay, so that is the suprascapular, but I normally do the entire superior trunk as a single bundle here. And can you see, it is only like a half a centimeter to a 1 centimeter depth from the skin. I haven't seen in the biggest patients more than 1.5 centimeter deep. Okay, it's a very easy block if you know what you are doing. So you are not in the conventional interscalene where you are looking for the traffic light. Yeah? You are going lower down, coming out of the interscalene groove, and this is the whole superior trunk. Okay, so that is the superior trunk block. Now into the abdominal area. So genitofemoral nerve, again, changing the machine for the next one. We will change the machine. Yeah. So the genitofemoral nerve. Is it okay? I will cover you up. Yeah. A little bit lower. Okay, so genitofemoral nerve, again, this is a technique that I was doing pelvic pain, yeah? Majority of the pelvic pain patients come with the genitofemoral neuralgia. They are females. If you go and read the literature, everything is about identifying the spermaticode. More than 51% of the population do not have a spermaticode, yeah? So we can't identify the spermaticode to identify the genitofemoral nerve. So I went to, I used to teach with Professor Moriel, and we were having a discussion, and this is something that was helpful, very helpful for me. And he said, you can use the reverse scanning technique. So I have written a chapter with Philip Peng in a book as well describing the technique, and we will show you that as well in the advanced. Okay, so we all know how we scan the conventional rectus sheath block. Yeah, so scan there. Then start scanning lower down, lower down, lower down, and what you will start identifying is, can you see that vessel? Inferior epigastric vessel. Yeah, identify the inferior epigastric vessel. Scan that down. We may have to increase the depth a tiny bit. Can you see that inferior epigastric vessels now? Beautifully. Go down, down, down to its origin. So it is coming down where it is arising from there. Can I have a bit more jelly, please? Yeah. No, it's okay. So scatting again, going down, 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 identifying the blood vessels coming, yeah, coming, which should be arising from the vessel there. There you go. And if you look at it, I'm going to keep it there. So this is almost like a V there. So you can see the left-hand side, you can see the artery there, and inferior epigastric artery is just underneath. And can you see on that corner, something is flipping in and out? Because Alex is Alex, yeah? So he has got a spermaticode. Can you see the spermaticode flipping in and out? Yeah? Can you see that? That is the spermaticode. Along with the spermaticode, on the lateral aspect of the spermaticode, can we freeze the picture there for me, please? Wonderful. And this is the genitofemoral nerve. How superficial it is. Yeah? So when you do your ilioinguinal ilioepigastric, you can do the genitofemoral as well from lateral to medial. And in females, this is a round ligament of uterus. You may not even see the ligament in a female who is pregnant or post-pregnant because that ligament is all gone. Okay, you wouldn't be seeing it. So what you are looking is the inferior epigastric artery coming from the top, yeah? Inferior epigastric artery coming from the top, which is joining the iliac artery. And this is like a V, and genitofemoral nerve curves around it. So go into that gap even if you don't see it as a nerve like this, what you can do is stimulate it and put some local anesthetic in there. You will get genitofemoral nerve. Okay? If you block, this is important for your hernia repair, any phalansteal incision, any lower abdominal incision. Yeah? So this is one important one. Okay? So I will quickly, how many more minutes I have got? 5 more minutes. Okay. Peng and genicular. Is that okay? Yeah? Peng is something everybody asks. Wonderful. Yes, put it back. Yeah, we'll change the machine as well. Can I have the other machine, please? Thank you. Everyone talks about the sensory block for hip and knees. Okay, it is the same block that we do, but sensory means you are blocking the sensory branches alone, and you can have a complete sensory block for both the joints. Okay, I use a combination of 0.125, 0.25, and also 0.5, depending upon which block I am doing. Okay, so for the knee, what we do is, yeah, we need to increase the depth. Okay, so let me put that one. So the genicular nerves comes from predominantly from the sciatic, femoral component, and also obturator. You have got 4 quadrants in front of your knee joint. So we do 4 quadrant genicular nerves. Okay, some people will do only 3. I do 4 as well. I'll show you the safest method to do the 4th one as well. Okay. 4 quadrant genicular, I use 0.5 or 0.375 or 0.25 depending upon the patient size. Okay? I do a conventional femoral. If you want to go back and check, many YouTube videos says do the subcutaneous branches. I don't bother because I have got a big femoral now. I can catch everything. It is so easy to do, quick to do. I don't need to hunt around all these tiny cutaneous ones. And I use 0.1 or 0.125. So there is no motor weakness. Okay, for the popliteal plexus, which is the back of the knee capsule, that I use the IPAC one. Okay, then one special tip for you. I will show you subsartorial saphenous nerve block. I don't do adductor canals. I don't do adductor canals because it affects motor function, especially if you are using higher volume, especially high block, the adductor canal block. It will cause motor weakness for the patient. So I do subsartorial. So the question is, when I block the femoral, why do I add subsartorial saphenous to it? This is the anatomical variation. Around 10 to 15% of the population, they have a contribution from the obturator from the back coming to that saphenous. So if you don't block it, that annoying patients will come and tell you, I have got a patch of pain here, and you can't do anything about it at that space. So when I am doing the IPAC, I do the subsartorial saphenous together. It's a couple of mils there. It serves the purpose. Okay. So for the genicular, this is like ridiculously simple. Okay, with ultrasound. If you can cannulate the patient, you can do a genicular nerve block. Yeah. So what I'm going to do is, so this is the knee joint. Yeah. So you go slightly upwards. You will see the muscle. So I'm going for the supromedial group. Okay. You can see the femur there. Yeah. And when you are coming towards the joint, can you see there is something called a flare? The flare is called, yeah. This is the flare. Can you see that? Yeah? Like a flare skirt. Comes straight and then goes out. That's the flare. So at the junction of that flare, you will see a lot of the tissues. And can you see a tiny little artery pulsating there? Because he is beautiful, beautiful anatomy and young, you can see all these arteries as arteries. In a 80-year-old arthritic, one of the reasons is entrapment of that nerve in there. You won't see anything. You don't need to see anything. That's the beauty. You go and touch your needle straight onto the bone. You don't even need to go there. Go to the bone there. Yeah? Infiltrate like a 5 ml. Okay, in chronic pain, we use 0.5 ml. 1 ml because we are doing something else for that pulse radio frequency. But in acute pain, be generous. 4 or 5 ml. You infiltrate and it will go around the joint like this. Can you see that? Yeah? You will see the spread as well. So you can do out of plane, hit the bone there, straight down. Yeah? Just infiltrate. Make sure the fascia is elevated from the bone. That is supromedial. Same on the superolateral as well. There we go. Again, looking for the flare. Yeah, there we go. And this is slightly less marked flare compared to the supromedial. Okay? Again, go hit the bone, infiltrate another 5 ml. Artery as well. You can see the artery as well, but not always you will see it. So even if you don't see it, don't worry. Now, the inferomedial is interesting for you. Inferomedial, we just really need to reduce the depth. Okay? This is almost like a cup. Can you see that? Oh, beautiful. Look at that. Yeah? Can you see? Reduce the depth. Oh, that is the lowest. Yeah. So can you see like a cup, and you can even see the artery? Can you see? Like a saucer. Yeah? And yeah, the artery also you can see. There you go. So go down there, infiltrate. It is very superficial, so you need to be very gentle when you inject, especially if the patient is awake. Yeah? And also, I will show you something else beautiful. Freeze the picture for me, please. Freeze. Freeze. Here. Yeah. Freeze. Can you see something here? So you know which nerve it is? This is the infrapatellar branch of the saphenous. This is what my surgical colleagues cut through when they put the scope in. And we get patients with a severe neuropathic pain afterwards. This is the nerve. Okay? So be mindful. And this is more beautifully seen if they have got a subcutaneous fat as well. So on the way back, I always look, if I can see, put a couple of mils in there. Yeah? That will do that. So inferomedial. Now, inferolateral is something. Everybody is worried about the inferolateral because of the common peroneal nerve. You don't need to worry about it. Okay? So what you need to do is feel the tubercle here. Okay? And here is the lateral condyle of your femur here. Yeah? And there is a ligament connecting these two, and your inferior recurrent fibular nerve, which is the sensory nerve, crosses it. So what you need to do is, you just put your probe like this. Some more gel, please. Thanking you. So instead of going out of plane, yeah, there we go. Can you see the ligament on the top there? And you can even see the artery just underneath there. Yeah? And most of the time, can you freeze the picture again, please? Yeah, freeze the picture. Most of the time, you will see the cutaneous branches coming here, sometimes close to the bone here as well. So what you need to do is, you just put your needle as in plane, inject underneath that ligament, that will catch your recurrent fibular nerve. Okay, so just to go back again, I know it sounds like a lot. Trust me, it takes less than 5 minutes to do everything together. So you have a 20 ml syringe here, one injection here out of plane, another injection out of plane here, another injection here out of plane. This is the only thing that I do, and freeze that, in plane. And because I'm coming from lateral to medial, common peroneal is far away. You're not going to touch the common peroneal. You don't need to worry about it at all. Yeah? Then the conventional femoral. Okay? Then I need the curvilinear probe now, please. Yeah. Sorry? What do you use for femoral? For femoral, 0.125. And I got probably 2 minutes before I do. So I'm just keeping his leg here for you to see as well. Okay? Because he is, again, wonderful anatomy, Alex, I could have probably used the high-frequency probe. But I wanted you to see how it looks like a curvilinear, because majority of my population, I need a curvilinear, even 100 millimeter needles. Okay? So I will show you how it looks like. So we can reduce all the way down, even lower down. Yeah? Okay, that's it. Okay. So if you are very familiar with your conventional adductor canal block, you can see that, yeah, sartorius, underneath that one you can see the artery there. Can we make it any better, the picture? Yeah? Screen, okay, more gain, okay, that's fine. So from there, what I do is scan down, where the artery is dipping down. Can you see that? Artery is dipping down, yeah? And on the top of the artery, there you go, where the pointer is, yeah? So you can see the sartorius, yeah? Sorry. Let me go back to a better picture, yeah, there you go. Yeah, sartorius, and going down, and the vessel is disappearing now. And you can see in that fascial plane, yeah? So I'm going to come from here, yeah? Not there, yeah. Okay, I will show you. 1 second. 1 second, 1 second. Yeah, can you freeze the picture, please? Yeah. Okay, you can even see one of the cutaneous branches here. Can you see that there? Yeah. Normally, in this fascial plane here, you will see the subsartorial saphenous. So everything underneath the sartorius moves here and the artery dips down. How the adductor canal works? Saphenous nerve alone is not enough for the knee. But how does it work? Pardon? Not only nerve to vastus medialis. 90% of the innervation comes from the sciatic nerve. How does it work? It follows the artery into the popliteal fossa. There are anatomical studies to show that. So how it works for the knee is because it goes into the popliteal plexus and it blocks all the nerves from there. That is why it works. Okay, so you can refine your technique and make it work. Okay, so for the adductor canal, sorry, the conventional IPAC, what I do is, so I start from the adductor canal, go down, identify the nerve. There we go. That you can see the beautifully there on the top. Can you see that? Yes, that is the subsartorial saphenous. Yeah, it's a superficial next to the artery there. Yeah, you can even see some of the cutaneous branches outside as well. Okay, so on my way there, I'll just inject a couple of mils in there. From there, you just flip your probe down. Can you see, can we increase the depth a tiny bit more, please? Bit more, bit more. Yeah. So you can see the entire posterior part of your capsule. Can you see that? Yeah. That is the entire posterior part of the capsule going down. Yeah. That is the artery you can see on the other side as well. So it is the space between the artery and the capsule. Can you see that? Yeah, this is the IPAC. So what I normally do is, if you can freeze the picture for me, please. There we go. Put your needle in. So I block this one, which is the subsartorial saphenous. Sorry, where is the pointer go? Yeah, okay, yeah. So from here, do the subsartorial saphenous, come back to the skin, redirect here between the artery and the capsule, and then inject. 10 ml. 15 ml if you have got a bigger patient. That's it. So that is, I think, time. Because we need to come back at 1:45 after your lunch. Yeah? I am there. Anytime, come and pester me. And there are all other experienced faculty around. Somebody will show you anything that you... Please follow all the odd numbers, odd number stations. Yeah? Even number groups follow the even number stations. It's very important. Yeah? That is the way it is set. Thank you. You will have a baby skin at the end. Yeah. Yeah. Okay. So whoever is seeing us online, this is the end of our morning session. Camera. This is the end of our morning session, and we are going to have lunch. Thank you very much for joining us. Hope you enjoyed. Give us any feedback if you have. And we will be having hands-on workshop afternoon. Next time, hope to see you, as many of you as possible, in our live scanning stations as well. I would like to extend my sincere thanks to Phil, who has helped us with the technical aspect, and also Alexandra in Paris, who helped to stream the scanning and also the whole session through the ESTRA channel, and to all the ESTRA office bearers and people worked behind the scenes. And thank you once again. Hope you all enjoyed. Have a wonderful day and enjoy the rest of the World Day of Regional Anesthesia from across the world. Thank you.
Recording stopped.